to call. I think we'll just start and see. Maybe before we specifically NPHCDA. And good morning to the virtual participants as well. It's good to have you with us again today. Let's start with prayers, please, and the national anthem, and then we will introduce ourselves. I think there are some new people here today that were not here yesterday, and go into the recap of yesterday's meeting. National anthem, please. Prayers and the national anthem, please. Second stanza of the national anthem. O God of creation, direct our noble cause. Not shall. They've changed it. So we don't have shall in it anymore. Where peace and justice reign. Okay. Let's have can you play the national anthem for us? You've been giving us very nice jams since morning. So please, let's have the national anthem. You can find it. Thank you, everyone. Please be seated. My name remains Juliana Abude Aribo, and I'll be anchoring with Dr. Francis Okuije of the WHO today. He sends his apologies, but he's also on his way. Please, where's the other microphone? Can we start with introductions? Have someone help pass the microphone around, please. Let's start from the backbenchers today. Please introduce yourselves. Name, organization.
Good morning, everybody. My name is Abdullahi Magama. I work with Save the Children.
Good morning, everyone. My name is Abdul. I work with Lisa.
Good morning, everyone. My name is Yahaya Oloriegbe. I work with Lisdale.
Good morning, everyone. My name is Tina Udoji. I work with Lisdale.
Good morning, everyone. My name is Oremolo, Lisdale's Communication and Online Content Management Specialist. Thank you.
Good morning, everyone. My name is Ademo Iwada Milola from Lisdale.
Good morning, all. My name is Okara Dogara from the Basic Healthcare Provision Fund, Ministerial Oversight Committee, Federal Ministry of Health. Thank you.
Good morning, everyone. My name is Dobra Emuren from the Federal Ministry of Health.
Good morning, everyone. My name is Polu Duke. I work with the International Society of Media in Public Health. Thank you.
Morning, all.
I am Isaac Uteno, here from Plateau State.
A very good morning to you all. My name is Ifedeli Chukwuekene Innocent. I work with Save the Children. Thank you.
I'm Mustafa Kurfi. I work for Save the Children.
Good morning, everyone. My name is Marvelous. I work with the Nigeria Governors Forum.
Good morning, everyone. My name is Rachel Lobe. I work with Center for Environmental Sustainability and Development Awareness.
Good morning, all. My name is Alhaji Godwin. I work with National Health Insurance Scheme.
Good morning, everyone. My name is Elizabeth Adeyemo. I work with Center for Health System Support and Initiative for Development.
Good morning, everyone. My name is Luke Alade. I also work at the Center for Health System Support and Initiative for Development.
Good morning, all. My name is Gafara Lauri. I work for DJI Consults.
Good morning, everyone. My name is Ali Bwala. I work with Options for MMA.
Good morning, everybody. My name is Emma Bassi. I work at Chai.
Good morning, everyone. My name is Maimuna Abdullah, and I work with Africa Health Budget Network.
Good morning, everyone. My name is Bello Halima. I work for Africa Health Budget Network.
Good morning, everyone. My name is Ajamila Mohammed Jantabo, and I'm a consultant working for LISDEL and BHCPF Secretariat.
Good morning, everyone. My name is Theodoro Samuel. I work with Nemo Foundation.
Okay, so while I see some others registering, please can we have the online participants introduce themselves, or let's acknowledge their presence. Can we see those that are online? So while we wait for them to put that up, I would like to welcome you all again to this very important and urgent work or mission that we are doing and trying to achieve. Yesterday, we had the workshop started yesterday, as we all know. And the purpose of the workshop is basically to review what we are all doing in the sector around accountability for basic healthcare provision fund, and see how we can enhance the outcomes of these activities around response around operationalizing the accountability frameworks with the ultimate goal of raising one accountability framework for the health sector. Yesterday, we sort of set the stage for building up to the discussions around the accountability framework, yes, for basic healthcare provision fund. So I'm sure we are all now aware that we have an existing health financing framework from which the basic healthcare provision fund accountability framework is to be derived. We had some presentations about on it yesterday that was made by Dr. Gafar, following, by Dr. Uzoma Nwakwo, the head of the health financing unit of the Federal Ministry of Health, around Nigeria's health financing landscape. And then Dr. Gafar of DGI Consult also made a presentation around the design and utilization of the health sector reform health financing accountability framework. So there were quite comprehensive discussions that were held, building on the presentations that were made. And we will go into that to recap shortly. We'll go into that shortly to recap takeaways from them and what the matters were and recommendations for moving forward. We also had colleagues from across the development world and civil society organizations give us a brief on what they've been doing around accountability, not just for the Basic Healthcare Provision Fund, but also for also around health security and some other health programs generally. And we went into a group session after that to look at factors that have inhibited or could inhibit or inhibit and facilitate effective accountability. So before we go into discussing what we learned from yesterday and how useful yesterday was, please permit me to welcome those that are online, our virtual participants. Perhaps we should have you all introduce yourselves. Madam Ifoma Dan Ogosi, could you introduce yourself, please?
Okay, so my name is Ifoma.
Please unmute yourself.
All right, sorry.
Or mute your mic.
And my mic is on mute. My mic is not on mute.
Okay, we can't hear you, Ifoma.
My mic.
Moses.
It's okay.
Would you introduce yourself, please? ED Youth and Dreams Initiative. Ifoma, are you ready? Still can't hear you. All right, so Adeni Ojo. Can you unmute them?
Hello. Moses Omtapa, ED Youth and Dreams Initiative.
Hello, good morning, everybody.
Hello, good morning.
Okay. Can you? Now, are you?
Hello, can you hear us?
Yes, yes, we can hear.
Can you hear me?
We still can't hear them.
It's your turn.
So I have Adeni Ojo. I'm sorry, because your organizations are not reflecting, I'm unable to say where you're from, but perhaps while they try to resolve the challenges you're having, can I see that page again? Put it up, please. The participants, while you're trying to resolve. Full, please. All right, so I see Anu Rotimi of Kite. Welcome. Kenneth Adagba, it's good to have you with us. Zainab Abdurrahman, Sekinat Sanusi. Nice to have you. Apologies for the technical. Okay, so we can hear you now. Can I have a full screen, participant, please? I'm seeing myself. Ifoma?
Hello, I can hear you, but you can't hear me, can you?
I can hear you now. We can hear you now.
All right, great. Hi everyone. My name is Ifoma Danagose. Most people call me Ify. But I live in London. I work as a lecturer and researcher at the University of East London. I was invited by Bolade Jimo.
Dr. Adeni Yojo, please introduce yourself. Okay. Can't hear you. Kenneth Adagba, your microphone is still muted. Adeni.
Okay. Yeah, can you hear me now? Hello, can you hear me?
We can hear you. Please go ahead.
Great. So my name is Adeni Yojo. I work as a program manager with Hanovia Limited here in Abuja. Glad to be online participating in this very important discourse.
It's great to have you with us. Kenneth? Please unmute your microphone. Your microphone is still muted, Mr. Kenneth. Okay, while Kenneth unmutes his mic, Moses, please go ahead.
Yes, good morning, everyone. I'm glad to be with us in this workshop. I'm Dr. Kenneth Adagba. I work with DGI Consult. I'm the State Program Coordinator for Kaduna State. Thank you.
All right, thanks. Moses?
Yes.
Okay, please introduce yourself.
Okay. I am Moses from Tapua, the ED of Youth and Dreams Initiative in Adamawa State, Numan, local government. Thank you.
Great to have you.
Yeah.
All right, so Anu Rotimi is online. Dr. Benson Obonyo, it's great to have you here with us, sir. Sekinat Sanusi, Ismail Abdul Razak, Fidelsi Umar Sadiq, Zainab Umar, Esther Okunola, Dr. Bolanle Olushola Faleye, Fatu Idachaba, Husseina Umar, Jimmy Dosumu, Michael Adiel, Ismail Abdulrazak, Simbiat Lawal, Marie Adams, Taibat Onize, Abdul Muhammad, Fatu Idachaba, yeah. Adejoke Olujimi. So it's great to have you all online. Do we have other participants there that I've missed or I've not mentioned, I've not acknowledged? I see 2 pages. Okay, so great to have you all online and with us this morning. We'll go straight to discussing lessons from yesterday, discussions, a recap of all that most of what we discussed yesterday and what came out strongly from conversations. And I also would like to welcome our lead anchor, Dr. Francis Ukwije. Thank you. So please, let's start with the recap. Who is willing to go first? Lessons from yesterday. So one of the discussions we had was around the capability or the capacity of the Federal Ministry of Health or the health sector to take on or to fill the gap that could be created if donors were to withdraw their funding from the sector. Dr. Okara took that particular, he responded to that particular question and assured us that there would be no gaps basically, and that the Ministry of Health is well equipped, right? To well equipped to, they have the capacity that they need to plan for any such eventuality. So I think I'm just going to pass my microphone around, basically.
accountability. It was really very eye-opening, giving that backbone to why we are here today. Thank you.
There was this catchy phrase from Dr. Alawade yesterday about effective deployment of accountability framework require institutional capacity, strong leadership, and value reorientation. It actually goes deeper than the surface, meaning we need more work to do for us to revalue the orientation we already have, and it just changes a lot of things and raises the accountability bar. Effective deployment of accountability framework require institutional capacity, strong leadership, and value reorientation. I was saying that it goes deeper than the surface, and it was a catchy phrase for me, and that includes the fact that when we do this, accountability bar is being raised.
Okay, good morning, everyone. I wouldn't want to repeat what everyone has said, but something very key for me is the fact that we all learned the importance of having a unified accountability framework for health financing as a whole, including the basic healthcare provision fund that will cut across the various stakeholders, the media, CSOs, partners, among all the related stakeholders. So I think that is very key. Thank you.
Good morning, everyone. I'll pick my take home from the group work, and looking at how reward, for excellence for those who were able to, inhibit the accountability in the activities. Somebody mentioned in the group how those that were able to, make sure that things are done as supposed to be, their fund will be released as at when due. They get the fund released on time to activate their activities. So for me, it was a good thing, reward for excellence when they. Thank you very much. For me, yesterday, during the presentation, there was an issue that came up in my group 5, which I think might play a very big role in facilitating accountability or hindering it going smoothly. That is the issue of judiciary, the role judiciary plays. Because you find out that in a country like Nigeria, even though on our own part we have FOID Act that people are not using well, judiciary can actually, through its rulings, make it impossible for us to get our acts together as concerning accountability, smoothness, and also they can also help in the sense that where there are bottlenecks for us to do our job, we can also get a ruling that can favor that to happen. So I think that area is an area that proper advocacy, whatever, every time we are setting up an accountability framework to do, we should ask the regional carry out our advocacy, so that in such a way that we can engage them appropriately to understand what we're doing, so that they will be in line with us. If not, like these politicians, they are too much.
You have given us another table. Okay, thank you. Mine is, I have 3 points to comment on. One is I've appreciated the fact that we all know where we're heading to, but we are taking different routes. That's number one. Number two, I so much appreciate the level of confidence the National Assembly demonstrated in reporting MDAs at a citizens forum. Is really commendable. Even though there are 2 schools of thought, some are saying the parliament are CS, while some are saying no, they are government. So I don't know, in Nigeria, there are more government than CS. Number 3 is a concern. I saw a slide around health financing, whereby the out-of-pocket expenditure was very high. I don't know if I'm the only one that noticed it. While the concern is not there, I have seen a point of intersection, a point of equilibrium, whereby the donor funding equates government expenditure. And at some degree, even the donors funding surpass the government investment. It's a really source of concern. We shouldn't be talking of only accountability, but favorable allocation. And that time wasn't an epidemic. So please, it's a source of concern. We should look at it. Thank you.
Right? And yet, releases and disbursements are still very low. So we need to start to maybe refocus, and this is my perspective. Should our attention be on allocation as we are right now, or where we are, or working with the government to improve efficiency? And again, one of the reasons why we are here. Dr. Gafa.
I don't know whether it was your presentation, but I saw a slide that depicts health financing, that out-of-pocket expenditure was high, and there was a point of intersection between donor funding and government expenditure. And at some degree, the donors funding even surpassed what the government is investing. It's a source of concern. That's what I was saying. Yeah, I know when they're that was
Check, check. Check, 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 check.
Okay, as we are all aware, The Basic Healthcare Provision Fund is basically a sustainable financing mechanism that intends to increase the fiscal space and also increase financing of health generally, with a view to having financial risk protection for all Nigerians and guaranteeing basic minimum package of health, strengthen primary health care, and then provide emergency medical services to all Nigerians. I will not bog you with the reasons why or what actually informed Basic Healthcare Provision Fund establishment. The reason being that we all know the reasons why such funds should be provided. It is obvious that the abysmal indices for health, as well as unacceptable number of high maternal and child morbidity and mortality in Nigeria. The Basic Healthcare Provision Fund takes its supremacy from the Health Act that was signed into law in 2014, specifically 31st October. And it underwent 10 years of evolution, back and forth for 10 years before it was finally signed to law. Specifically, and of interest is Section 11.1, which states that there shall be established Basic Healthcare Provision Fund. And the two part of it also stated how these monies will be shared. The 11.2a, sorry, the two part of it stated how the sources of this funding. The 2a states that not less than 1% of the annual consolidated revenue fund will be made available for implementation of the Basic Healthcare Provision Fund, while the B part of it says that other fundings from grants from international development partners, while the C part of it says other sources, which include spirited individual. While Section 11.3a also gives a direction to the classification and categorization and allocation of these funds. In particular, the A part of it says that 50% of this Basic Healthcare Provision Fund will be made to provide basic minimum care of health services to all Nigerians through the NHIS gateway. While the B part of it says 20% of this money will be made available for vaccines, consumables, while the C part of it says that 15% will be made for repairs of health facilities and transportation, while the D part of it, which says 10% of these monies will be used for human resources, for health, and in that order. So as a way of background, the Basic Healthcare Provision Fund implementations started specifically on the 8th of January 2019, which was launched in Villa by Mr. President. But before the launch, there were preliminary activities that took place. The federal government of Nigeria secured a grant of 20 million US from the World Bank. And that money was made available to pilot in 3 legacy states. Those states were Abia, Osun, and Niger states. And in the same vein, the 2018 allocation, that is appropriation, federal government, was also made. About 55.1 billion naira was appropriated, but 27.2 billion naira was released for the implementation of the Basic Healthcare Provision Fund. Sometimes in 2018, the first manual was actually launched. However, in 2019 September, the Basic Healthcare Provision Fund was suspended at the instance of the National Assembly, where the Honorable Minister of Health was directed to review the manual because the implementation was inconsistent with what was in the Act. So the manual was reviewed between 2019 and 2020. So the old manual was referred to as manual, while the new manual, that is 2020 manual, is now referred as the guideline. In 2020, so the program of the basic healthcare provision program was suspended between 2019 and 2020 when these guidelines were being developed. Then in 2021, the Ministerial Oversight Committee was inaugurated in February, while the Ministerial Oversight Secretariat and the director was appointed in April 2021, while some of us were drafted into the Basic Healthcare Provision Fund Secretariat in May 2021. So we're about a year in the Secretariat. So I think it's important for us to have this background because a lot of questions will keep coming up. So the objective of the Basic Healthcare Provision Fund are actually 5. One is to have 3 functional public-private secondary health facilities in at least 50% of the states within 3 years and all states in the next 5 years. And to also provide emergency medical services through provision of ambulance services, to also strengthen the primary health care, specifically to have 1 functional PHC per ward, and then 30% of the wards in 3 years, then 70% of the wards in 5 years. Then also to reduce out-of-pocket expenditure by 30%, and also to improve life expectancy to at least 60%. The overall objective of the Basic Healthcare Provision Fund, as earlier mentioned, is to provide basic minimum package of health to all Nigerians, strengthen the primary health care system, as well as provide medical emergencies to all Nigerians. One of the accountability framework of the Basic Healthcare Provision Fund is the governance structure. It is in this way. The governance structure is headed by the Honorable Minister of Health, which is the Ministerial Oversight Committee is the highest decision body making of the Basic Healthcare Provision Fund, which is headed by the Honorable Minister of Health. And then the alternate chair is the Minister of State, while the permanent secretary is the vice. The members of the MOCs includes the heads of the agencies, primary healthcare, NHIS, MTC, NCDC, directors in the ministries whose departments have relevant activities on Basic Healthcare Provision Fund. Development partners are all part of the MOC. And as part of the governance structure, again, there are gateways for there is a gateway forum for all the gateways where they meet from time to time to discuss issues and have a way forward resolving their own problems majorly. So what is obtainable at the federal is also replicated at the state. At the state, the Basic Healthcare Provision Fund is the State Oversight Committee is headed by the Honorable Commissioner of Health and has similar members as mentioned at the federal level. Likewise, at the local government level. And then, to me, the strongest of all is the WDC, the World Development Committee. They are very key in the implementation and utilization of services as long as Basic Healthcare Provision Fund is concerned. And then it also has the BHCPF disbursement pathway, that's the financial pathway. As earlier mentioned, and as stated in the Act establishing Basic Healthcare Provision Fund, this was it. That is 45% MPACDA, 50% NHIS, and then 5% EMT gateway. However, with the establishment of the NCDC Act, section 14G1 of the Act states that 2.5% of the 50% basic healthcare provision fund shall be under the Act shall be used for NCDC. What that one means is that with the establishment of the NCDC Act of 2018, it has consequentially amended the National Health Act to mean that the 50% that is for NHIS, 2.5% of it will be taken for NCDC. And if you do your mathematics, 2.5% of 50% is equal to 1.25%. So it also means that NHIS now will be entitled to 85.27% of these funds, while NCDC will be entitled to 1.25%. This is the position of the law. I'm just a messenger, but that is what is on ground. However, if there are issues, the law are there and can also be amended accordingly. Now, again, as stipulated in the Act, this is the sources of the money. However, for partners who intend to bring their monies in, like my Oga here, Dr. Francis, who wants to bring in his monies for basic healthcare provision fund, there are two pathways. It's either he wants his money to be commingled with the 1% consolidated revenue fund, and it will be shared in line with the formula for allocation, or if he has specifications for which he wants his monies to be used, there is a dedicated TSA account that monies will be domiciled there and will be used according to his specification. So there are flexibilities in that order. Again, the states are also expected to provide 25% as counterpart funding, which is also a demonstration of their own commitment. The next slide is on accountability. So we're coming to the crop of the matter. Yesterday, issues of accountability kept coming up, and Dr. Gafar did justice to it. But what is this accountability all about? It's basically the obligation or willingness to accept responsibility for one's action. And if you are said to be accountable, it means to be answerable to one's action and be liable for your own consequences. So basically, that is what it's all about. For the sake of this presentation, I decided to separate what is enshrined, the accountability framework that is enshrined in the BHCPF guideline, from what we are actually implementing now in terms of accountability framework. So in line with the Operation Guideline 2020, the accountability framework is divided into three components: the funding component, the governance component, and programmatic components. So for governance, it has a broad indicator, then description, and then responsibility. For the broad indicator, the first one is proportion of states implementing primary healthcare under one roof, as well as having functional state health insurance agencies of schemes. And of course, with the availability of that on ground, it's track PHC repositioning, and then also attempt to eliminate vertical and fragmented approach to implementation of programs. And the responsibility is for the Honorable Minister of Health, State Assembly, State ES, primary healthcare. Regularity of meetings, MOC, and gateways, which is also key. It provides room for synergy and proper coordination. Regularity of same meeting at the level of the state is also key, as earlier mentioned. Then for funding, The accountability framework looks at proportion of consolidated revenue fund allocated in federal government budget for basic healthcare provision fund, and also proportion of appropriated funds that are released. We all know in Nigeria that it's one thing to appropriate, it's another thing to release. So people will say, IMAC. Again, also looked at proportion of eligible health facilities receiving quarterly funds within 10 days of release or approval in line with the guideline. Proportion of states that have actually paid their 25% counterpart funds, a proportion of state and agencies or both, and local government areas releases such funds too. The next accountability framework in the guideline is the programmatic component, that is the program management. The broad indicator looks at timely submission of proposals, work plans and projects, also looks at regularity of submission of the quarterly programmatic and financially reported. One thing is submission, another thing is timely, because you can be submitting it at will and at irregular timing. Proportion of local governments have submitted collated quarterly business plans and operational requirements to state agencies, both proportion of PHCs submitting quarterly business plans, previous quarter retirement through the local government health authority to the state primary health agencies, and proportion of WDCs meeting regularly and interfacing with the primary health care. Then the next is accountability measures that are currently implemented under the Basic Healthcare Provision Fund. We are taking them level by level. At the level of the Ministerial Oversight Committee, the Federal Ministry of Health has engaged the Office of the Auditor General of the Federation through an MOU for the auditors to audit all activities, both financial activities of Basic Healthcare Provision Fund, from the level of the MOC to the gateways, state, and the level of health facilities. As I talk to you now, any moment from now, in the next 1 week or so, the auditors will go into the field. It's huge work. It has a lot of financial implication, but for the purpose of accountability and transparency, that has been taken and is also very key. Conduct of ministerial oversight meetings. Since we came on, but since the reverse of the work plan, so reverse of the guideline, 2 ministerial oversight meetings have been held. One on the 1st of June 2021, and the second one was held on the 18th of November 2021. So first quarter of this year has not been held, but any moment from now, the 3rd Ministerial Oversight Committee will be held. And then also ensure functional state oversight committee, because you cannot have a functional ministerial oversight committee and have a weak state oversight committee. They have to go concurrently. As I speak with you, next week we're inviting the commissioners and the focal persons at the state for capacity building on operations of Basic Healthcare Provision Fund. We have also intend to be publishing all disbursements on 3 daily newspapers. As I speak with you, we've also gotten approval to publish the 2021-2022 disbursement that was met in December. That should be this week. Within the end of this week, that publication should be available. But I have the soft copy I can share with this meeting already, since it has secured approval of the Honorable Minister and the Permanent Secretary. So, Dr. Gafar, you can start your accountability framework from there. Submission of both programmatic and financial reports of the MOCs to secretariats. Okay, submission of the reports to the secretariat has been very key. The gateways have been submitting their reports to the MOC secretariat for review and endorsement or approval, as the case may be. Then periodic conduct of supervision at the states and health facilities by MOC. We just came back from the field last week. When the field, I personally visited Plateau, Bauchi, and Gombe, from the states, SOCs to the agencies, and I visited each state. I visited 6 health facilities. We're working on the reports, and other team also went to other states. We will get the reports out, and the experiences in the field actually is amazing. And there are other lessons learned from the field that we got. So under the gateway of the MPHCDA, the MPHCDA has been conducting regular and robust M&E quarterly to ensure that they track the progress of the implementation of basic healthcare provision fund at the state and facility level. And then also submission of business plan by the end of every quarter. It is expected that the health facilities will develop a business quality improvement business plan through submitting it through the local government and the state SOCs, which will be forwarded to the gateways, specifically Primary Healthcare Development Agency, for their review and approval. And that business plan is used as an MOU, quote and unquote, Dr. Ogbe. I don't know whether I'm right. The business plan that is submitted to the Primary Healthcare Development Primary Healthcare Development Agency is served as an MOU between the agency and the facility. You are now telling them that we are going to implement XYZ activity within this stipulated period of time, and therefore they are held responsible. That is why such work plans are submitted and are being reviewed from time to time. And that work plan is also approved. Disbursement of funds within 10 days received and subsequently state disbursed to PACs within the same stipulated period. Submission of retirement funds on quarterly basis in line with the approved protocol. So what that one means is that what the work plan you have submitted, your retirement should also be along that side. You cannot say you want to train X number of health workers. At the end of the day, you go and purchase generator with the money. That will not be approved when it comes to retirement, and there are punitive measures that are being taken. Regular conduct of verification stroke spot checks on programmatic and financial activities are being also carried out. Submission of MIE, programmatic and financial reports is also being done. So those are also form basis of the accountability framework for MPHCDA. Then for the NHIS gateway, they have also developed work plan premium and have distributed these templates to the state's insurance scheme or agencies, as the case may be. That templates form basis for uniformity and consistency. It means what is being done in Kano should also be the standard in terms of quality, and all that should also be done in Bayelsa and other parts of the country. Criteria for disbursement of funds to states health insurance reviewed and approved by MOC. Yes, the NHIS gateway did not just sit on its own and continue to watch. The first disbursement they did, they realized that there is need for other stringent measures to be taken. So what they did was that they reviewed the criteria and then brought in other relevant criteria to ensure accountability and framework. So they have reviewed it and it was approved by MOC, and that is what is currently being used for disbursement of funds. So what that one means is that the basic healthcare provision fund is not, the implementation is not casted on stone. There is room for a review. There is room to change innovations if it is not working. There is room to review the work plan, provided that due process is followed. There is also quarterly fund tracking by the state's health insurance agencies. There is strong MIE system to ensure compliance to program activities. There is also capacity building When I came this morning, I was looking around to see some of the input that were made. I realized that most of these things were also captured there, because if you're not capacitated to carry out your job, you may not even know what it entails to have an accountability framework. They have also developed grievances, redress, and sanctioning mechanism. So there is also a carrot and stick approach. Those that are doing well, something is given to them. And then those that also fall foul of the law, they are also being punished appropriately. And then there is also vetting of claims arising from secondary health facilities. It also means that the National Health Insurance does not just go and pay claims just like that. It has to be verified, meeting the minimum criteria before the secondary health facilities get their entitlements. These are broad indicators for tracking the implementation of basic healthcare provision fund. I just extracted this one from the manual too. Basically, it looks at number of accredited health facilities receiving payments for services financed through the social health insurance mechanism, tracks number of public primary health centers receiving operational expenses via the decentralized facility financing, percentage of health facilities financed through the social health insurance mechanism whose claims are found and valid, not less than 10% discordant from the claims as independently verified, average health facility quality of care, number of beneficiaries receiving services financed through the social health insurance mechanism, proportion of states with functional medical response services, percentage of annual decrease in out-of-pocket expenditures. Yesterday, I came across this slide and I adopted it. When I saw it, I now remember the discussions we had yesterday about accountability framework, and it's basically reflected here. This slide shows the enablers of accountability framework, and it is also very clear. If you look at the discussions we had yesterday, the key thing that kept coming out was transparency. If you are not transparent in what you are doing, you cannot also be accountable for it. It also talked about participation. Some people hold certain programs to themselves as if it is their personal property. You have to let everybody know. And basically that is the accountability. And you should be liable for what you have done. And then talked about complaints and responses. You should be able to leave the doors open to accept complaints and then address those complaints accordingly. And then issue of project monitoring. There is this saying that you can only manage what you can measure. Therefore, measurement in everything we do is very key. Even in our day-to-day activities in our homes, we measure. So it's very important in terms of transparency and accountability. And it has to be strategic in nature. You can't leave it to chance. That time? Oh, okay. So I'll stop here. When I've been direct, it's part of accountability, man. When you are told to do this, you should do it. So how many minutes do I have, ma? How many minutes? Anyway, this is the last slides. Mr. Francis, Dr. Francis, sorry. So in accountability framework, you have to be strategic. You don't leave everything to chance. You have to be deliberate in what you are doing, and planning is very key. As well as corporate monitoring, we talked about that. Strengthening performance management in every organization is very key. An organization has to be strengthened in terms of performance management in order to achieve their set goal. On this note, I say thank you and thank you for listening.
Okay, so Dr. Kara, don't go far because we will put you to task to answer some of the questions. Yeah, oh yeah, no worries. So I see Dr. Priscilla Ibekwe, a director in NCDC, representing the NCDC and the DG NCDC here, leading her team. So we expect that Dr. Ibekwe will also make a presentation on behalf of the NCDC. So you're ready right now. So please help me welcome Dr. Priscilla Ibekwe.
Thank you very much. I'm usually a shy person. Why are you guys laughing? Oh my God. Oh my goodness. You don't believe me? Okay. Oh my goodness. So, okay, so I got you. To make sure you hear and see. You can open my laptop. Let me start, or yours. Open your laptop. I'll just make a start. So thank you so much for this opportunity. We're so excited on behalf of the DG. I want to thank the organizers for inviting us to this meeting. It was so important to the DG that the day before, 16th, the DG, one of the people in the office of the DG said, Madam, are you going for this meeting? DG wants to be sure. And to be honest, I ran to this meeting, sat down, and actually forgot that I was supposed to be in training that I initiated, my own training. So I forgot. That's how important this topic was to DG. That's why I kind of stepped aside for a few minutes and then came back on. So I'm just going to be briefly talking about the public health, the basic healthcare provision fund and public health emergencies. And I'll also talk about our accountability because I know the focus is about accountability. So next. So I just will start by saying that our country is at a risk of infectious disease outbreaks. Next. And it's not surprising because we all live, where human beings are living within the interaction of animals, their environment. And the great thing now is that the world is such a small village that one infection going on in one country would just get to Nigeria before the end of the day. So we are at risk and we also have to be prepared all the time. But we do have some endemic outbreaks that occur. All slides will be given to you and please share our slides. Next. So Nigeria experiences so many outbreaks. We've had the Ebola. It's just these are some of the big international things, but some things happen to us and with us. We've got the monkeypox. It's always in the news. Recently in the news. Meningitis of 2017. More than 100,000 people were affected. Over 1,000, 14,000. Please forgive me. About 14,000 people were reported in 2016 with meningitis, 1,000 deaths. One death is too many. Now we have the monkeypox, the COVID resurgence of polio. Lassa fever happens every year. It's not because I think we live with rats, we live among rats, or rats live among us. That's why I said the interaction between man. I'm always fighting rats in my house. So. Because even if you are clean, your neighbors may not be. So I live in a place where, and then I don't own my house. So I'm at the risk, I'm at the mercy of the landlord and what is ready to do, okay? So, and then our Gary is put on the road. Even here is NCDC. Before you get here, all the people in Otako put their food out. I mean, so it's not somehow we go and buy those anyway. On my way home, I'll pick it up. So we're at risk. I eat the suya man thing, and he's using old newspaper from my house that I kept somewhere. That's our reality, okay? So we're at risk of Lassa fever. Cholera outbreak was so annoying last year. Over 60,000 people. Many countries don't know about cholera, but last year, over 60,000, 3,000 deaths, more than COVID that the world is talking about. But we have to respond to all. Next. So I have this slide for a reason. And that's the fact that as at March 24th, we had total number of cases of COVID was 42, 2 new cases confirmed. Now, exactly 1 month later, we had 1,000. So that is to tell you how quickly something can escalate. At which point is that emergency? That's the public health emergency. The problem, you see, when I came into NCDC, Chikwe and this new direct DJ, let me start with my experience. Everything was so fast. You need to do this. In my mind, I said, I did not do public health. That's my personal experience. I did not do public health so that I will be on the edge. I'll be in an emergency room. But when I sat back and reflected it, I now realized that these viruses are traveling. And if I don't respond today, more people, okay? So we need to act fast. These are our total numbers, but I just want to say what starts off little can really blow out, okay? Next, please. So 31st, China tells WHO that we have COVID. By 26th January, 3 weeks later, we had already established a national corona preparedness group. We're already anticipating, but before this group was anticipated, we have a department in NCDC that does risk assessments. Once we hear any news, we're already doing risk assessments, okay? So a lot of things have happened. By February, you have this slide. By February 20th, we already had 4 labs because we did a risk, based on our assessment, this is airborne, it will come from the airport, most likely. So we made sure that the gateway already, because of the gateways, we make sure that the laboratories by the gateways would at least have something. And then we confirmed our first case, and the rest is history. For 4 labs to over 80 labs in the public sector, we have about 157 labs now, molecular. So I'm only using lab to show you that we were both responding and preparing. And that is not the right thing to do. You should prepare more than you rest, you know? Okay, so next. So we are guided. My presentation will end in the next 3 minutes, so I'll keep to your time. But just to say that our health security is guided by the International Health Regulation. We did joint external assessment to determine how strong is Nigeria, how prepared are we. We developed a plan and we are working our plan. It's multi-sectoral. Next. So for the basic healthcare, and we're using the funds, we decided that we'll have we're looking at it like 3 blocks. Emergency outbreak, public health emergency coordination center, making sure this is part of preparedness, that you have a good room that people can sit and coordinate a response or prepare. Reference laboratories and have networks of public health laboratories and digitalized surveillance. There's no point getting any figure if it comes to you 2 weeks after. That was what happened in 2016, 2017. They were using spreadsheets, email, and all that stuff. It doesn't work. We want real-time data. So we have what is called the developed by Nigerians, developed by us, surveillance outbreak management response system, that if somebody in my local government, a surveillance officer enters data, it is seen at the state, and we can also see that data at the national. And this is now being used in several parts of the world, including developed countries. So there's so much that we can show the world. Anyway, so we are looking at outbreak response fund. No matter how much we've got, we have to put some money so that we can send people to the field as soon as they say there's a problem. Stockpile for commodities. Like I said, you have treatment centers, a reference laboratory, and also public health, and ensure that we're able to peak real-time data and sustained data bundles. Next. So basic healthcare, we have only received in 2018, we received only 1/4 of money. That's our accountability going on here, 361 million. But I just want to say that money is not enough. And now in the allocation with the 1.25%, the total we are going to get so far this year, if released, is only 380 million, which is less this year. A whole annual is just like 1/4 of what we got earlier, right? So we are yet to be included. The MOC, Ministerial Oversight Committee, has included NCDC as a gateway, but no money has been disbursed since. Next. What did we use our money to do? The first one we were given. We trained, meningitis is a problem. Clinicians can't take blood, fluid from the back. So we trained them in Sokoto, River State. We wanted to design a patient treatment support system for Lassa fever, where people don't pay if they have Lassa fever, because if they have Lassa and sit down at home, they're infecting more people, okay? But we just designed the system. We haven't funded it, it's not implemented yet. Then we did stockpile, bought some response vehicles and laptops. Nobody can work in NCDC without a laptop. This meeting, she's responding. We're all over. Somebody right now was supposed to be talking to me and I don't know that the person is in Côte d'Ivoire. I just texted, he's in Côte d'Ivoire. We have to do a Zoom meeting, okay? So we are always responding remotely. Next, please. So we established 5 EOCs, trained people, also assessed treatment centers, renovated Brigham University and equipped it. Next. So what is our accountability mechanism? We have established a unit, a PIU. So if you need information regarding what we've done and what we're doing, the PIU can do that. We have a dedicated account that is now mingling with other accounts, okay? Then we have, like that circle says, now it's like, it's great to come to places like this because somehow we did this without seeing those circles, the last slide from the last presenter. We have a monitoring and evaluation framework that we are implementing. We also have activity reports, quarterly reports, annual reports in both program and finance. We developed a complaints mechanism, so it's so much to take. We regularly report to the NCDC management and to MOC and whoever would ask us to report to them as appropriate. Our program report for basic healthcare is online. Okay, so if you Google basic healthcare NCDC program report, you'll find it. So we are transparent, at least in uploading our reports, where we respond to the external audits that he said. They did some, okay? Both external, go to the field, we leave them, we tell them this is where things are, you go. And a forum like this that I participate in, or we participate in, is also a forum where we're saying we're here, this is what we've done. You can ask whether it's true. Now, just to show you some of the evidence of what we've done. Next. This is Kwara State, EOC, what it was before and what it was when we renovated it and made it more functional. Next. Again, they provided training and it's multi-sectoral. If you are from Kwara, please feel free to ask your guy from home. Next. They have their documents, Osun State. Next. That is the one that happened in Osun. Like I said, it's multi-sectoral. So we get the police and all the military people because it's a team. Next, please. Next, next. Okay, so we trained, this is the number of people we trained. You want the report, we're happy to send it to you. Next. Okay, that's the LP training. These are the people that attended. That's how we're showing them how to take fluid from the back. Next. Yeah, next. Sokoto team for the training, 58 clinicians. Continue, please. Now that's the Brigham Center. They couldn't wait to use it for COVID. Next. That is KB training for summers. See the number of people who came to that. Next. Yeah, so this is just a summary. I think I'm almost there. Next. Is it moving? All right, thank you. So I'm saying this, these are the pictures. If you are in those states, either for work or you come from those states, be accountable. And when we go to states and we are doing something for the states, we go on air and let the people know that this is for you. And it came from basic healthcare. Thank you.
All right, thank you very much. My auntie that is shy. Yes, she's actually my auntie. We come from the same place. All right, so we have questions and answers right now for the presentations that we have heard from the MOC representing the 3 gateways and then the NCDC. So can I see your hands up? Then I count you. So the first hand up, not you, sir, you will be number 2. So number 1, number 2, sir. Sir, you are number 2. Yes. Number 3, number 4, number 5. And that's all, right? So let's go in that order. Oh, yes. So do we have, I can't see. So please, if you can bring them on. Let's see who is raising hand on the online platform. Then we can recognize them. Yes.
Thank you, Doctor. Thank you, sir. Concerning the BS, wonderful presentation. And in fact, I was with a Big Mommy presentation. I was like, okay, oh, so NCDC is doing so much like this. Wow, it was a wow for me for a presentation. But my question goes to Doctor for the BHCPF. You know, you said something about trying to harmonize and then making sure that what is obtainable in, say, Bayelsa is also obtainable in Sokoto. I want to say something about Nigeria being in a humanitarian setting. There are times may not be a one size fits all. Like Borno now, for example. Let me not even go as far as Borno. Let me pick Abuja here, where we have influence of IDPs. And I can tell you, many of the camps, they are so far away from even the PAC, even the selected PAC, even not all, both either selected or non-selected PAC. And we've seen situation where they are so cut off. And for people like us who believe so much in BHCPF because we've seen what it has been doing at community level, how it has been able to reach the unreached. You know, I don't know whether there's any mechanism being put in place not to, at least to absorb this group of people, say IDPs especially, that are being cut off entirely, you know, from this, because this is one thing that I know that can easily reach them because they are naturally unreached. So this would have been an avenue, you know, to reach them. So that's it. Thank you, sir.
Okay. So what mechanisms do we have in place to cover the guys that are in hard to reach areas, especially the IDPs? Thank you. So please give to him, Dr. Henry Ewunon. So I see Charles Aniweze online. So you will be coming in by the time we take the 50% from the room.
Thank you. Good morning, everybody.
Good morning. Okay, thank you very much, Dr. Henry. And number 3, yes, please take the microphone to Dr. Gaffer.
Okay, thank you very much. I would like to join others to thank the presenter for the great job. So I would like to start with Dr. Okara. Thanks you again for that great presentation. So my first question is this. Apparently you have a very robust arrangement for collecting data, even from subnational level at national level on the various aspects of performance of basic care provision fund. So the question is that, do you have a mechanism in place where state actors, non-state actors will be able to access this data easily, analyze it, interpret it, and use it for accountability? That is number one question. The second question is that don't forget that basic care provision fund is an intergovernmental fiscal transfer. It's the money of federal government going to subnational level to improve health system, but at the same time to catalyze investment at subnational level as well. So as part of our accountability mechanism, what mechanism do we have in place to ensure that the states are not just receiving this money? The money in terms of course, it serves additionality purpose, fine. But at the same time, it's supposed to catalyze the state to invest, because in terms of absolute amount, if you look at the investment health needs in Nigeria, is basic care provision fund is just like a drop in the ocean. So that is the second question in terms of catalyzing subnational level investment. The third question is that from the accountability framework you showed, I think that's an abridged version, I know. But what I did not see is that because you defined accountability earlier on, taking responsibility for actions and inactions and all those stuff. What are the consequences for not meeting some of those targets that you have there? If a state or national level things supposed to be done, it is not done. What are the consequences of not doing that? Then to Dr. Ibekwe, I will not join order to say Dr. Ibekwe is shy because I know her very well. So Dr. Ibekwe, thank you very much. And I think we have to appreciate NCDC for something, or for many things, but on this occasion, for the step they've taken to increase transparency around spending of the Basic Care Provision Fund. I think SCDC is the first recipient of the Basic Care Provision Fund that I know that actually published on its website the details of spending of the Basic Care Provision Fund. That anybody can go to the website, okay? Anybody can go to the website and know amount to receive. And if you want to contest it, because you have the data, you can contest it. She said she did something in Kwara. And when next I go home, I will find out whether it happened in Kwara or not. But my question for NCDC, because when Dr. Adogara made his presentation shortly before you came in, she said the reason why NCDC is not as yet to get disbursement from this current stuff is that NCDC is yet to develop a manual for the implementation of Basic Care Provision Fund. So I want to find out so that Dr. Dogara will not just continue to keep the NCDC money in his pocket. What is the plan of NCDC to develop a manual which will facilitate access to this Basic Care Provision Fund? Over. Thank you very much.
All right. Thank you very much. Number 4. Who is number 4? You are number 5. So go ahead. If number 4 is number, oh, you here? Okay. Oh, okay.
Good morning, and thank you very much for your presentations. My question is for the second presenter from NCDC. Thank you again for your presentation. From the presentation, it looked like everything happens very smoothly without a hitch. So my question is, with the fast-paced nature of health emergencies and the need to work in a multi-sectorial collaborative approach, what are some of the reoccurring challenges that you face when working with people from other sectors? And what recommendations do you have to mitigate such challenges, especially when it comes to challenges that cause delay in response, in the spirit of accountability, so that we can know who to hold accountable when there is delay? Thank you.
Okay, thank you very much. And then the final question from the room, please give to Dr. Emure. Dobra.
Thank you very much. My question is to NCDC too. I didn't know you had developed a manual for implementing, but my question was to ask, were you going to use the BHCPF Provision Fund to respond to all public health emergencies, or you have a criteria to utilize this fund? Thank you.
Okay, thank you. And then I think, yeah, Charles Adinweze, please. So,
okay, thank you very much.
And speak to us.
Yeah, I have done that. Can you hear me clearly?
I hope, Charles, you can hear us from the room.
Yeah, can you hear me?
Okay.
Hello, good morning.
So
can you hear me?
while we prepare to have Dr. Charles and his questions or comments, we probably need to start from the room to begin responding. So who is starting first? Is it Dr. Ibekwe or Okara? Okay, yes, all right.
Thank you for the engaging questions. Very interesting, and I'm glad to answer them. So do we have mechanisms for non-state people to access the data? Yes, we have mechanisms. When you look at there's so much information on NCDC that is online. So if there's something you are looking for and you don't have it, then you can ask me, okay? But a lot of our guidelines, your data, reporting across diseases, what is being done, reports, it's all, NCDC publishes 98% of what it has internally. The only 2% that is not published is the fact that somebody is slow in putting it up, okay? So we are open, transparent, and we want you to have the information. Then in terms of the manual, the MOC says we should develop operational guideline and manual, which we have developed and sent to the Minister of Health. So we have sent something to you. So I'm just waiting for guidance on what to do next so that we can have these funds as soon as possible. Then the nature of what? Okay, when we think about the fast nature of emergencies, the challenges of working with other people. Now, I'm glad somebody mentioned about 22 billion or whatever the cost of the National Action Plan is. That National Action Plan is not NCDC plan, as in it's for NCDC to deliver. It's about a big chunk of it, over 50% of it is immunization. That is for primary health care, okay, to deliver. So it's about the whole sector, the different sectors, both in health and outside health, agriculture, environment, to deliver. Now, the challenge we have, and again, we have the One Health strategy, trying to bring these three sectors together. The challenge we have is that some of our sectors, other sectors, are not as fast, okay, in responding to things that happen to health. So that itself can be, they're sometimes a bit slow. So we need your help to advocate. And sometimes even the people that come to meetings are not the people who have the power to make decisions. So I think it's you're as part of your accountability role, where you are in meetings and the right level of staff is not there. I think you need to speak up, because if I said something here, I'm not saying I'm the DG, certainly not, but I can at least give you a reasonable NCDC position on it. So it's good to send the right people to meetings who can take things back and make decisions and not wait for so many levels. And again, in NCDC, we train our staff, we try to train our staff well so that they're able to represent us reasonably well. They will try to make them as knowledgeable as can be so that they are useful in meetings. I've got a member of my staff here, and I believe that it will take time for her to make those presentations and give a reasonable information as required so that people can make decisions at the table. So you also made something around the money can't be enough. I agree, the money is not enough, but the thing is, it doesn't matter what allocation you have. We are in government. Sometimes the allocation for your statutory work, the one that comes every quarter, it doesn't come as fast as it should come. And if you have an emergency, you have to dip into the pot that is open. So for example, recall the NCDC, recall the COVID-19 that happened. It's happened in the first quarter. And we know that usually in the first quarter, there's literally little or no money. Am I correct? In most people's table. It was the basic healthcare fund that you could carry over. That was the only fund available at that time that sponsored a lot of the meetings that we were holding. Without those meetings, there is no response. So you have to, while you put monies, you have to deal with the emergency as is. But we will be very accountable to where we got the money from and how we spent it. Thank you. Is there any question I didn't answer? I need to rush to a GF meeting now. Yes, sir. For me? Okay.
All right. Thank you very much, Dr. Bekwe. I think the rest of the questions are for Dr. Okara. Where is Dr. Okara? Okay, please hand the microphone over to him for him to respond to those other issues. And I think the other members of, the other managers of the other gateways, MPSC.
All right. Thank you very much. Madam, are you going? I have a question for you. Okay, because you made mention that the manual has been developed and has been forwarded to the Honorable Minister of Health. So I'm just wondering, in the interest of this meeting that we have accountability, if you are developing a manual, are you not supposed to engage relevant stakeholders in order to avoid duplication of functions and creation of gaps? Besides that, I just called Dr. Chris now in the minister's office. He told me that he has not seen the manual. However, he spoke with the NCDC DG. He told him that the manual is still on his desk. They're yet to forward it to the minister. That is okay, except if you want to respond to it.
No, just to, it's just information actually. Yeah. I think the decision at the last MOC was that they should draft a manual. So we'll now meet on that draft. That was the instructions to them. Because they said they cannot use the money and they cannot get it without a guide. So they should draft something. That's what people will now meet on and finalize. So when it gets to the minister's office, the MOC will call for a meeting to review it.
I'm coming to you now. And give you, I'll send you the receipt.
It's okay now. It's on a civil service thing. It's in transit.
Okay, so I think that is sorted out. So there is evidence that that document was submitted. So thank you very much, Dr. Bekwe and team. Okay, so there are other issues that were raised that we would like Dr. Okara to respond to. So Dr. Okara, please go ahead and respond to those other issues that were raised by stakeholders.
All right. Thank you very much, Mrs. Priscilla. All right, let me respond to the first question. Sorry, I don't know your name, ma. Bosse, okay. She asked two questions. The first question is, considering the diversity of Nigeria, how do we reconcile having one template, a single template for different regions? The template that was developed by NHIS is not in terms of activities like maybe transportation, where you buy camel in Sokoto and in Bayelsa you buy boat. No, it is in terms of quality of care. Of course, you cannot compromise. You cannot compromise. So there should be a minimum standard to provide care wherever you find yourself in Nigeria. The second question is, what mechanism is in place to reach to the IDP? If you look at the process for enrolling these clients for basic healthcare provision fund, it's for different states anyway. Some states use the National Social Register, where the names of the poorest of the poor and the indigents are there. While some states make use of their World Development Committee, who are resident in that committee, they actually know who is poor and who is rich. Therefore, let me respond to your answer. So for those IDPs that are resident in that locality or committee and are being identified by the WDC, for sure, it should be captured as part of the enrollees. The next question was by Dr. Henry. Okay, that the act itself, I guess, section 11(3)(c), which talks about transportation and maintenance of health facilities for the MPACDA. is not for buying of ambulances. And I don't think MPSCDA has used the monies of the Basic Healthcare Provision Fund to procure any ambulances. Dr. Ogbe is here, he might throw more light. However, if at all that is also mistaken for the EMT gateway, it is very clear that the Basic Healthcare Provision Fund will not be used to procure ambulances for such services, but ambulances will be assembled from private organizations who intend to provide services, and that will be used just the way Uber and Bolt is being used, but monies will not be used to procure ambulances in any way. The next question you asked, the B part of it is, how has BHCPF reduced maternal mortality and child mortality? I think it is too early for us to have an impact evaluation of the Basic Healthcare Provision Fund, considering the fact that the program was suspended between 2019 and 2020, and actively implementation commenced again in 2021. I totally agree with you that there should be an impact evaluation of this particular program so that we also benchmark the resources that are being used vis-a-vis the gains and then set objectives of the program. The next question was from Dr. Gafar. Dr. Gafar, you made mention that the NCDC money is in my pocket. You know, they are kidnapping now. I'm just a messenger. That money is in TSA in Central Bank. So it's not in my pocket. Anyway, that was on a lighter note. Do you have mechanism? The first question from Dr. Gafar, whether there is any mechanism in place where the non-state actors will monitor and analyze this basic healthcare provision. Yes, it is. We are coming up, we are inviting the partners for a meeting. We have had the first meeting with DPGs, Development Partners Group, and those were the issues that were raised. So shortly, any moment from now, we shall call for another meeting where we will develop on mechanism of monitoring and evaluation. So you will also get to know about it. So the answer is yes, there's a mechanism for non-actors to independently verify what is being submitted to the Ministerial Oversight Committee. The next question is, who is this person? What mechanism are in place to ensure that the states do not mismanage the Basic Healthcare Provision Fund? From my presentation, I attempt to highlight some of those activities put in place. First of all, to even start with, before the money, not the issue of money. I have to ensure that when we send the money to them, the state government are actually spending more money. All right.
How the states contribute more.
So they don't duplicate.
The Healthcare Provision Fund stimulates more investment
Good.
at the subnational levels.
Thank you very much. Thank you very much. Thank you very much. There has been advocacy, outgoing advocacy, and even part of the publications we are going to make in the newspaper this week is going to be there that the Basic Healthcare Provision Fund is going to serve as an additional funds and not a replacement of the state budget that is supposed to be meant for health. And again, they develop a separate business plan, which is separate from what the state has, so that they don't duplicate functions. And this business plan, as earlier mentioned, they are being submitted through the local government, through the state, and up to the gateway. And those business plans are the ones that are being held, like in form of a memorandum of understanding between the gateway and the implementers at the state and the health facility, to ensure the needful is done. So by the time we start publishing the monies that are being paid and benchmarking it with the total amount of expenditure, health expenditure in the state, I think the state will also sit up. During the 71 million lives program for result, there was what they used to do as a naming and shaming, publishing the states that are actually utilizing those monies, and states are also contributing monies to the basket in terms of health. So I think something of that nature can also be used. So the third question you asked, Dr. Gafar, was, what are the consequences for not meeting these targets? We have just said it. From the NPACDA gateway and the NHIS gateway. At the NPACDA gateway, if you don't develop your business plan, if you don't submit your retirement in line with the business plan that was developed, you will not get the next tranche. So that is a punitive measure on its own. And other measures are there, monitoring and evaluation to ensure that is tracking the implementation to ensure that it meets its objective and others. Then at the NHIS gates, we had in my presentation where they have to verify the claims before they are being paid. And even the criteria for the payment to allow them pay to state health insurance scheme, and for the health insurance scheme to also remit such funding in forms of capitation and fee for service. The claims must be adequately reviewed. I agree with you that there is work to be done again, and that is why we're meeting here to develop this accountability framework to see how we can strengthen these measures. However, they are also here, the NHIS gateway officers are here to also speak for themselves. I think this is the last question I have jotted, except if there's another one that I didn't get. Thank you.
Okay, so what we're hearing and from the discussion so far is, of course, we have something that is existing even in the guidelines. So, but that's just the foundation towards developing a very robust and appropriate accountability framework for basic healthcare provision fund. And that's actually what this discussion today and the whole of yesterday and today will take us to. Yes, so Dr. Obe is raising his hands, but before Dr. Obe, let me read this out. So, and there is one of our colleagues, Oluchuku Obele, online that want to ask questions. So perhaps Dr. Obe can just wait a little. Let's hear from these guys, and then we can take all the next round of discussions on the questions that have already been asked. Oluchuku, please go ahead.
All right, thank you, everybody. I don't know if I'm audible enough.
Yes, you are.
Okay, great discussions. I'm sorry I couldn't join in person, but having listened to the NHIS representative, I just have just two questions to ask. One is around the M&E framework that he presented. Again, it seems that we are, as a country, we are too ambitious. I would want to see a situation where the M&E framework for accountability purposes is benchmarked in a way that we have a short-term target, a mid-term level target, and also.
So Oluchuku, there is something you can do for us. If you can hear me, please put down
Yes, I can.
your comment on the chat so that we can see. It looks like there are network challenges. Thank you very much. So this one is from Charles. So he is talking about, say, as I provided consultancy to a state in implementation of the Basic Healthcare Provision Fund, supported by USAID late last year, I found out that the accountability framework for the programmatic level is not strong. Primary healthcare IOCs are collaborating with the WDCs to cheat and defraud the system. They do the work plan together in certain things that will enable them make money. So the question is, who actually monitors the OICs The present accountability framework did not give responsibility to the LGA admin assistants who these OICs report to. The next question is, what is the place of independent accountability monitors from the private sector in the Basic Healthcare Provision Fund accountability framework? So I guess these ones will now help Dr. Ogbe to respond accordingly. And I understand our colleagues from the NHIS have just a few things to add. So we will also want them to just come and do that as soon as Dr. Ogbe finishes his intervention. Dr. Ogbe is here. No, we won't take that hand now. We need to manage time. So let's talk to Dr. Ogbe and then we can move from there. Who is raising the hand here? Oh, you. Don't worry, we can take that later on. Okay. Yes.
Okay. Good afternoon, everyone. Thank you for the opportunity. It's good to be here. Sorry, I couldn't be here throughout. I had my team members here from the start. I think before I address this question specifically, I just wanted to say a couple of things. So Dr. Dogara did a good job of presenting the accountability framework. And we all know, and the idea of that, just like Dr. Francis said, is setting the platform, the foundation on which the accountability is built. So the idea is that the various gateways will further expatiate on that and tighten and detail it all the way from the top to the very bottom and find a way to a mechanism to enforce that accountability at all levels. And that's ongoing at different degrees. So it's not perfect yet because in reality, that's it. If we have been on any of our other presentations, so we move on the trajectory where we started to just get the gateway going, get the frameworks on, start implementation. Then we're now at the point where what we are doing is tightening financial tracking, accountability, monitoring, and evaluation. So that's the stage we are. So that's my current focus. So we had a recent support from a partner to try to bring all these pieces of accountability we have and create a very tight framework that answers one question. Because what I told them was that I need to answer one question. If the Honorable Minister is in a meeting and suddenly called Dr. Fazer, and when he calls Dr. Fazer will call me, Dr. Ogbe, let's go. And we get there and he says, can you show this meeting how we are ensuring that every Naira sent through the MPSCD gateway has been accounted for, right? So a concise way of pulling together all we do from the business plan process approval, all the way to the retirement, all the way to all the audit checks we do, tidying it up into an accountability framework that can be monitored and mentored. That's what we're in the process of doing now. And that is the singular reason, minus the fact that a presentation has been made by the MOC where we didn't make a physical presentation. And we're trying to do that with a partner, but it hasn't worked out. We've not been able to conclude it. So we're working on that. So I'm really looking forward to the outcome of this meeting, because we need to really shift away from where, like I mentioned jokingly to my friend, that is this National Assembly. They are saying, come and tell us what they're doing for accountability. What we really would like to see is the outcome of the meeting that now begins to bring up mechanisms, particularly for the community level. So we have said, yes, it's important for CSOs to be part of it, but how are they part of it? So a CSO working in Bauchi, in Bayelsa, in Enugu, checking 3, 4, 10 facilities and saying this is what we found and escalating it in their local sectors, which is very helpful to work with them at that level, does not translate to a national framework that we can view, monitor, and report on. But we think it's really important that the CSOs are part of this process. But the challenge is, how do they become part of that process? How do we organize them in a manner that they're able to work locally and also report nationally? Who funds them to do this process, right? How would that happen? And how will this process be part of a building mechanism so that there's a problem, the problems are solved, they are addressed and improved upon, as a process that is just designed only to just say how bad government is doing? So these are some of the challenges we have had in trying to build in that CSO. If you look at the guidelines closely, you see that the CSOs are well stated there as part of that mechanism. But the biggest question has been the funding. Who we fund them? So we need to find how we can get the CSOs, those that have maybe regional umbrella bodies that have those working under them that have reach, and see how we can organize that mechanism so we can integrate this into the gateways so that we get a systematic way of reporting and feedback and action right? So CSOs are not just monitors. They are not just monitors and people that call out when things are wrong, but they need to be part of the mechanism to say, okay, this is wrong. These are the recommendations. This is how we're going to fix it and get it fixed, as opposed to just telling government, you're doing bad, you're doing bad, you're doing bad. And nobody's telling government how to fix it. And nobody's ready to participate with the government to fix it, particularly the lower levels. So I wanted to put that on stage. So we really hope the final outcome of this meeting will be structured in a manner that we can actually use it to scale the accountability framework to the very grassroots in a manner that it goes there, it acts locally, but it's able to also to report nationally. So we can say this is what's going on, this is what it's doing, and all of that, right? So I just want to bear that in mind. So the specific questions that were asked in terms of the business plans to start with, yes, there's a lot of conniving. There's nowhere in the world, once the issue, it's money, and people have the opportunity, there'll be some level of conniving, even in the most transparent and best countries we refer to. But the challenge has been, just because one of the biggest challenge we have in the MPSC gateway particularly is the operation funds. It's too minimal. It's really very little we can do with it. But luckily, what we did with them this year is that we actually had to, like, it was a struggle to even get the approval for that kind of meeting, because I said I want to call the states to come and sit down and let's develop their work plans together. Why are you calling? Don't know how to develop work? I don't know how to develop work. They just send their work plan. But it was important because we're able to now take every single state, because they all get different amounts. How much do you have? What are the priority things we need you to do? And I agree with them, how much goes to what. So unlike the previous year, because it's like the second year they're doing work plans to implement. Unlike last year, they got money, they just do one activity and say, without money again, and they got just 6 million for a year to run operations. It's not going to go anywhere. So now they have slightly more. So we're able to detail it. So we expect that no matter how minimal, some of this monitoring and checks will now actually take place, right? Because for instance, because of the detailing, they're able now to train their people to start conducting the routine quarterly assessments, which they could not do before because there was no more. But now they know we have this amount for it. Then we have this amount for all of that. So what should happen and what the design is that the states should have, the LGA officers are appointed as mentors and supervisors to the BHCPF facilities. On average, in a local government, we will have between 10 to 20 BHCPF facilities, most times about 12 to 15. So we said as people are assigned not more than 2 or 3 facilities to an officer at the local government. He's the one that goes there, but the challenge has always been no money. So but this year they have some small money assigned for that particular purpose. So when they submit their business plans to the LGA, the idea is that at that local level, somebody looks at the business plan and say, this is not right, this is not possible, because the business plans don't get to the national. We have about 6,000 facilities now receiving DFF. If you send 6,000 business plans to me, next year is when I'll start looking at them. I won't even start this year, I'll just keep them. So we'll start reviewing it next year, right? So it stops at the state level, right? And they have the eligibility, what they can spend that on. And they've all been trained, health workers trained, WDC trained, state people trained on that. And now we're looking at how we can put some of those models online so that it's available for refresher. They can just go this kind of WHO, World Bank models that is self-spaced. You can learn, it can assess you so that they can just on their own do that. We hope before the end of this year to have some of those critical models for some of these things to be available for anybody to download, go through and all of that. So the idea of the thing about idea of the WDC being part of it, because they're co-signatories to the account, the business plan has to carry the WDC signature, is that it's not because we can fight everybody and ensure everybody is honest and all of that. But we think if we leave only the WDC to do it, that the problems will be far more because they don't know what to do. They'll just spend money on painting the building and spend the whole of the money. If we leave the health workers to do it, right, the challenge is that they will just do what they like without consideration for the community needs. By putting them together, the thing I always tell people, nobody steals the community money twice. You can only steal it once. Because the time it goes out, when the community demands things and they hear that it's chairman that signed with health worker and we don't know what happened, there will be accountability at that level, right? But this is where we need the CSOs to come and at that level. But when they submit to local governments, local governments will review it and endorse it before they forward it to the state. So at the state level, they now say, okay, we'll receive a business plan. And if it's okay, they now release their DFF to them. We also are aware that is not really happening into that level, particularly in states that don't have direct partner support for the BHCPF. Because if states will receive 200 business plans, the man is just going to say 200 and they have submitted now, give them their money, right? But so what we're also hoping to achieve by the end of this year is to move the process online so that they can submit this business. Not all of them are able to submit it, but a majority can, because it's once a quarter. So even if the OIC has to collect 3,000-4,000 naira for himself and travels to the next town where there's a cyber cafe to fill in the thing online and submit, then we're hoping to be able to create some parameters based on previous plans or reports that the states would still have to make effort to fill into the system that can now flag business plans that are out of order and allow the state to at least review those ones in detail so that they know what they are approving. So the point of it is not because there's no mechanism. We have the MPSA Gateway Handbook. We have done training for the states. We have the training manuals. All that should be done is outlined. The honest truth is that we actually got a consultant from one of our partners to come and review our financial tracking. The man stayed with us and came to me and said, your financial tracking is okay. I said, what do you mean? I designed it and I'm saying I'm not comfortable. You're coming back to tell me. I said, I put in a report now that is okay. Right? So everything that we should do, we've detailed it. So the problem is the intensity of its application. And to do that, the states have to have more operational resources. Partners that are supporting the states need to directly support operations, not just, because I guess there was in a meeting, I found out that some of our partners working in some states have so much data and in-depth work they're doing on the BHCPF in those facilities. But we're not getting those, but we're demanding the same report from the states and it's not coming. So it means the partners are probably not even sharing this with the state. They're just working parallel to them. Some of them have 20 personnel, 30 personnel in a state working on BHCPF. I should be going to sleep for those states. I should just be calling the ES. What is it? And they you just collect the copy and send to me. Those states, okay, these states are sorted. But that's not happening. So it's that intensity that we need to work at. And I hope when we get the outcome tomorrow and for this academic work, we'll be able to detail it in a manner that can actually help us do some of these things. So those OIC, the person that is responsible is the local government mentor first, or the local government health director first to cross-check those business plans, because it just has 10 or 20 to cross-check. So you can actually spend a week, and the time frame we give them is enough for him to spend a week to review those business plans before they are submitted. I'll round up now. Then at the state level, that's where the final say is to finally clear it. The second one was about private sector monitoring. So in the guideline, the MOC, so what we didn't want, we did not want standing IVs like we use in NSHIP. Why? They're too expensive. NSHIP engaged just for 7 states, engaged about 7 or so IVA. Each was received nothing less than 100 million. That's almost $1 billion. I don't get $1 billion in overhead, right? Nobody does. So they're too expensive. What the guideline says that the Honorable Minister at any point, if he's dissatisfied with the reports that the MPACD and the NHIS and the MTGD are submitted, he can appoint an independent person, a third party, to go and do the monitoring and report back to him so that I can cross-check our reports. Even at our level, we are also able to engage private sector to support us in doing our work. So we need to go monitor there. We don't have the manpower, we don't have the time. You go monitor, these are the criteria, and submit a credible report to us, right? So that is really the main clause. If somebody partner came and said, has given us 10 billion standing funds for monitoring alone, I will be happy to engage all the people. But the second reason, and this is really very important, but most of the partners here also want all these private things, is building the system. So you have a private sector monitoring that I have to train. I have to train. When they're doing the NSHIP, we train them from scratch to go and do the monitoring. Most of the time when they submit the reports, we virtually have to write the reports on their behalf, right? But then you don't build the system. So is it the private sector person you're going to hold accountable for what has gone wrong, or government? Right? So government should be able to say, a unit in government of 5 people should be able to say, well, we've recruited these people to do it on our behalf, they've done it, and this is our report as government. Right? So those are the mechanisms, the system building things we must consider in integrating private sector work into government work. So I think if there are no more questions, I'll just stop at this point. Thank you very much.
All right. Thanks a lot, Dr. Obe. So our colleagues from NHIS are here. I think we will go on a short break, and it's going to be a walking tea break. So we will advise that immediately after this discussion, so people file very quickly behind. So pick your tea, come sit down, so that we go into the next business on the agenda. So NHIS, please.
All protocol duly observed. I am by name Al-Haji Godwin. Just to add a few things to what the presenter from the Federal Minister of Health has presented, because all the gateways are reporting to the Ministry of Health, and he gave a summary of our activities. We just briefly want to show us what to have as activities in our accountability frameworks, what we track, and why we track them, our dashboard, the activities we report, and what we are expecting from those things. But before then, I wish to tell us that the process of developing an accountability document is at the finishing stage in NHIS. Whatever we're presenting is an extract from the draft. It has not been validated. Yeah, next slide. Yeah, this place, we are looking at the action, the activities in our accountability framework, what we track and why we track them. If you look at the first specific objective, we are tracking to ensure that governance structure at all levels is fixed. You know, in the guideline, it's expected that there is oversight committee, state health insurance agencies is set, World Development Committee is set. So in our accountability framework, we are tracking this to ensure that there is 100% functionality of these structures. The second one, we're also tracking to ensure that we have target population and that we have to know the number of enrollment from that target population, whether we have enrolled this targeted population 100% or not. The essence of this tracking is to ensure that 100% of potential beneficiaries out in the targeted population is what? Enrolled. We're also tracking to see that all the healthcare facilities in this operating under the Basic Healthcare Provision Fund NHIS Gateway meet a minimum accreditation requirement. We are talking of quality of services that is supposed to be provided. There can be quality when you bring in anyhow facilities on board. For there to be a quality, there must be accreditation criteria. And we are tracking all these criteria in our accountability framework to ensure that those that are on board meet minimum accreditation criteria. We're also tracking to ensure that the enrolled beneficiaries has access to 100% of the minimum, basic minimum package of health services. Next slide. Also, the indicators we are tracking continue in the accountability framework under NHIS Gateway. We are tracking to ensure that there is compliance with procurement regulation, guidelines, and processes for efficiency cost, and so on. We're also tracking that the provider payments at all levels by shares follow approved payment mechanism. There is stipulated number of days that capitation has to be paid. If claim is submitted, there is stipulated number of days that this claim has to be processed, stipulated number of days that this payment has to be made from the time it is submitted. So we are tracking all these as indicators in our accountability framework to ensure that these are stipulated in the operational guidelines are achieved. Of course, I've been given just 5 minutes to show us these indicators, so I don't need to waste much of our time. So this is self-understood, but these are some of the indicators we are tracking in our framework. Next slide. So here, another element in our accountability framework is performance monitoring and reporting. We use performance monitoring to monitor performance of the program, and there are various reports. We are monitoring performance of the program to ensure that the implementation is in line with the stipulation in the operational guideline. If not so, then action has to be taken. And we see the various forms of reports that are there as checkmate. Somebody that comes in, if minister calls us, what is the level of this, the level of enrollment, the accreditation, the number of accredited facilities out of how many facilities. You can see we have under the report, we have programmatic reporting. There we are talking of the number of enrollment, proportion of enrolled beneficiaries, that is the total number of enrollment out of the targeted enrollees. Then financial reports, we are tracking the amount paid per capitation, the amount paid for fee for service, the amount disbursed by NHIS to share, and those disbursed from state health insurance agencies to the healthcare facilities. All this, we are tracking them to ensure that as stipulated is achieved, because if it's not being followed strictly, you will discover that the enrollees might not be able to access the basic minimum health packages. Next. Then in this place, we have our performance reporting dashboard. We have the Monitoring and Evaluation Division of the National Health Insurance Scheme has developed a dashboard. Of course, it's a tentative tools for measurement because there is NHIS program that is ongoing. Before that come on board, that all our activities, all our monitoring will be by ICT. We are using this Excel dashboard. We have developed data collection and data collection tools, which has been the M&E officers of this health facilities has been trained. They have been trained. The State Health Insurance Agency, their M&E officers have been trained on those data collection and collection tools. Then we have registered that are domiciled at the facilities, informations on utilization, capitation payment, and all of those things registered in the recorded in the register that is domiciled at the facilities. The MIA officers at the facility will transfer those information to the data collection tool, which will be forwarded to State Health Insurance Agency. At the Health Insurance Agency, they will summarize the information, which will be entered into the Excel sheet, which is online Excel sheet, and our dashboard. Those information will be automatically downloaded in the dashboard, and we'll see them in summary in this form. Under programmatic performance, performance of program, you will see enrollment coverage for the whole country. We can see them per state. We can have maybe proportion of enrollment. We can think of, if we aggregate all the targeted population in the whole country, out of this targeted population, what is the proportion of enrollment? We can get that in our dashboard at a glance. Then healthcare providers, the number of providers. Then we can talk of proportion of providers out of the whole providers in the country, which proportions are on board. Financially, we are talking of proportion of healthcare facilities that receive capitation, payment for fee for service, and all of those things. At a glance, we have also Excel dashboard as a monitoring tool. Thank you so much.
Okay, thank you very much. So this provides a lot of clarification towards the NHIS Gateway Accountability Framework. I know there are colleagues who are asking some of those questions. So I think it's still work in progress. We expect that by the time we're done from here and moving forward, we would have been able to harness the experiences of institutions and agencies and CSOs and individuals that are already tracking to firm up what we already have as drafts from the MOC and the gateways. And I'm actually excited about what I'm hearing from all the stakeholders. Everyone is happy to work together to have a robust accountability framework for health financing and basic healthcare provision fund in Nigeria. At this point, I truly don't think there is anything that is keeping us from going to take tea. But remember that you are going to collect the tea and come back to sit so that we go into the next item on the agenda. Thank you very much. Basic healthcare. Can I ask Dr. Okara Dogara on behalf of the MOC to come take his seat. Please, a round of applause for him. Dr. Okara, are you still taking tea? How many minutes do you have? Or do you want us to give you? No, you are not on any high jump. We are working together. Thank you very much. Please, a round of applause for him. So may I also ask the representative of the African Health Budget Network to come take his or her position on the high table here. It's on a so it's a hot seat, eh? So we're putting you on the hot seat. So what's your name? Okay, Memuna, please, on behalf of the African Health Budget Network. So Madam Juliana will represent Lisdale. Please, a round of applause for Juliana. She's clapping for herself. So we're waiting for you to take your seat. So I want to also crave the indulgence of Mr. Sati. So he is from the Federal Ministry of Finance and specifically the Budget Office of the Federation. So this man is one of those behind the scene that help the health sector to get our money. You might not know, but he is on the health desk of the Budget Office of the Federation. Please, a round of applause for Sati. We need to thank him so much on behalf of the Federal Ministry of Health for all the work he has done. He has been on this desk for as much as I can remember, not less than 10 years. So all the health budgets that you see and allocation, he makes them happen. And well, we have 2 females and 1 male. I would have loved to bring our colleague from Kaduna State. I think the only representative of the Kaduna State government, of the state government here. I don't know about others, but we heard we heard from them and have good experience implementing accountability framework in Nigeria. So please, what's your name, ma? Jamila, please, on behalf of the Kaduna State government, Kadman, right? So please go and take your seat. Please, a round of applause for her. Okay, so the panel is formed. For those of you who are sitting back, please, I took this from this table. Please, while you are enjoying your tea, join us. The first phase will be with structured questions that we have. The second phase will be facing you. There are quite a good number of us who had questions or other comments, but they couldn't because of time during the last session. This is an opportunity for you to do so by the time we finish with this first phase. So I'll start. And I am going to be starting from government, no doubts about it. So I go to Dr. Okara on behalf of the MOC. So when we say accountability framework for the Basic Healthcare Provision Fund, I hope they have the microphone. Where is Secretariat? Please, there is no microphone on the panel.
Thank you, sir.
Thank you. So when we say accountability framework for the Basic Healthcare Provision Fund, what comes to your mind? What do you have as a vision? Because why this is important is because we don't need to, I think it's a Yoruba adage that says you don't shave one's her in his or her absence, right? So you are the government. So let us know, what do you have in mind? What's your vision around accountability framework for the basic healthcare provision fund?
All right, thank you very much. What comes to my mind first when you talk about accountability framework is holding the implementers of basic health provision fund responsible for their actions and inactions. And they should also be accounted for accordingly. In the near future, I intend to see a basic healthcare provision fund where it's going to have a very strong accountability framework in terms of thematic areas, in terms of governance. We intend to see a governance structure that is very strong, a governance structure that is transparent, that is accountable, that is open, that is responsible to its citizenry. We intend to see an accountability of the funds. The funds should be used for the reasons they're meant for. We intend to see where the poorest of the poor, the indigent and the vulnerable Nigerians will access and have access to the basic minimum package of health, where the primary healthcare will be strengthened, primary healthcare system will be strengthened, as well as have emergency treatment services available in a transparent manner. Thank you.
All right, thank you very much, Dr. Okara. And so while we were answering that question, a number of things came up. So, and what that really meant was that there are supposed to be what anybody needs to concentrate on, what anybody needs to focus on when you are thinking about an accountability framework for the basic healthcare provision fund. So what it means is that there are the basic components of the accountability framework which you had mentioned, and then of course the levels of tracking of that accountability framework. So based on that, I need to go straight to our colleague from CADMA. So what do you see as the basic components of accountability framework for the basic healthcare provision fund? And at what stages, at what levels do you see these accountability mechanisms instituted?
Thank you very much. So I think he rightly mentioned the components of the accountability framework. This should be around the area issues of governance, talk about the issues of funding, and then we talk about the issues of program implementation, program management. So for funding, we go around looking at releases, what was released, what is cashback, what is given at what level, PHC's accreditation, monies released and monies used, what for the funding, entire funding of the basic healthcare provision fund. And I would say at what level we will be looking at, or we look at different levels from the local government to the state level. And from the local government, we're talking about even at the PHC level, we should be looking forward to the role of WDCs, for instance. We understand that they're very instrumental in the implementation of the accountability mechanism. They are the ones to develop the business plan, to submit to the state level, the state primary healthcare development agency submit to the national. So I would say that this is very critical at the state level. We look at the primary healthcare development agency, the 3 gateways. They are also critical when designing and implementation of the accountability mechanism. And civil society, the government, being very active from the design of the accountability framework to the implementation of the accountability framework. from releases of funds, from management of resources, that is, from also the implementation provision of services at the service providers, that is the PHCs, to the state level, the policies, etc. So the entire cycle of the implementation of basic healthcare provision funds need to be taken along when in the implementation, or from the beginning, that is the design and the implementation of basic healthcare provision funds. And when we say levels, I want to mention that at the PHC, it's very critical, and to the state level, the PHCs, we need to take the ward WDCs, that's the WDCs, the ward development committees, the CSOs, the state-led committees at the state level, the PHC, the gateways, and the general oversight, the health oversight committee, health sector oversight committee. Thank you.
All right, so thank you very much. So that's Jamila, right, from Padman. Now, I think I heard you very well. So while you were going through the various components and the various levels where this accountability framework to be instituted. So it looks to me that it comes from the very lower level of the communities.
Yeah, right.
Then it goes up to the health facilities, and then of course at the health facilities as providers with the various individuals and actors within the health facility goes up to the local government, from the local government to the state, from state to the federal.
Yes.
And then there are a lot of stakeholders who are involved in this. So based on this, I'm going to ask this question to Juliana, representing this. So the orientation and the idea is that civil society will be the eye of the citizens, being the watchdog on the government and other institutions that implement health interventions, and in this case, the basic healthcare provision. So just like we have seen the continuum of the persons and institutions that are engaged in this whole process. So how do you think that the civil society will ensure the engagement, the meaningful engagement of all these actors, even including the parliamentarians, in ensuring that there is a good buy and effective implementation of accountability framework? Yes.
Thank you, Dr. Francis, and every other person that's spoken concerning the accountability framework. How we ensure that the CSOs, right, can reach or ensure that the fund is working across all levels. I think that's one of the reasons why we are here today. I know that that's one of the reasons why we are here today. Dr. Okara's presentation earlier, he spotlighted the fact that the Basic Healthcare Provision Fund guideline already has an accountability or an M&E framework. From what I saw, though, I think it primarily focuses on what the MOC and all the gateways are meant to be tracking. That would definitely apply to other structures of that we've come to see as civil society organizations, in quote. It would be important for the civil society organizations to first of all understand what the Basic Healthcare Provision Fund is about, what is meant to deliver. Like Jamila explained, at what levels, how it fits into the overall health systems, the health field, both the health financing, the health system strengthening, the health reform that we are currently undergoing, what is meant to achieve. Dr. Henry talked about something earlier. He said he wanted to know how the impact around maternal mortality would be tracked. And Dr. Okara said that it's too early to do this. All of these fits, they are integrated. Now, we would need as civil society organizations or civil society representatives to understand also the M&E framework or the accountability framework and expand it to begin to track, for instance, what denominations or denominators we're looking at or looking for, the numerators, the sources, right? And engage all the various, so the arms of government that are involved in this, right? As well as all the stakeholders that have so far been identified. But instead, is very important that this is done using evidence that's coming out, the tracking that's coming out. So it's not good enough, pardon my language, to always like say, oh, this is not working well. What's the government doing? What's the legislature doing? But when we have the accountability framework and an action plan also would need to be developed. Of course, there are issues around sustainability and how to track, or funding for logistics to track, to conduct the tracking or operationalization of the framework, right? But first of all, we have to have a robust accountability framework that everyone that's acceptable, adopted, right, and owned by all the stakeholders that we have talked about. And that's why we have all the gateways here. I think we've had quite rich discussions, conversations, even with Dr. Kara, about who should own the accountability framework. Where should it be domiciled? Who should be the custodian of it? It's already in the Basic Healthcare Provision Fund guideline. The guideline is already owned by the Basic Healthcare Provision Fund MOC Secretariat.
Yeah, we'll come to that.
I'm going too far.
Yes.
All right, so I can stop.
Yes, you can stop at this point. Thank you. We will come to the issues of institutionalization. But before then, so I will go to Sati. So he represents the part of government that does allocation for health. And where he sits, he has seen it all over the years in terms of how this prioritization is normally done. And indeed, he also superintends over the analysis of the spending. So I think I need to come back to him to ask that question about how to ensure that accountability at various levels from where you sit. I remember we had a meeting with the Minister of Finance recently, and part of what the Minister of the Finance complained about is that we all talk about giving more money to health, but they know that the health has not utilized appropriately and most effectively and efficiently the fund that you do appropriate every year. And one of the things she asked us to do as WHO is to support them in finding how to ensure the efficiency of utilization of a health fund. So from where you sit, sir, what is your take on this accountability for the money that you appropriate for health in Nigeria? Yes.
Thank you, Dr. Francis. I think anything that has to do with money, that's where our attention comes in. I was just thinking um, when the presentation from the Basic Care Provision Fund Secretariat were making their presentation, and it's from the Health Act 2014, but all the focus has always been on the Basic Care Provision Fund. That's where the money is. So as if it's a case of you buy a television, once you remove the television set, whatever is inside, you just jettison it. Coming back to the Basic Care Provision Fund, one unique thing about the Basic Care Provision Fund is captured as statutory transfer. And funds under statutory transfer gives you some level of autonomy. Do as you like with your money. And one thing I want to appreciate about the at least, because I see if it has become the norm now that is 1% of the CRF is at least 1%, as I understand, which means all things being equal, if we're ambitious, we can increase it to maybe to even up to 5%. Now, looking at the accountability framework, now for agencies or programs that actually funds are released under the Basic Care Provision Fund, it doesn't really give us from our own angle to be able to incorporate it into our own system. Because one unique system about GIV mix that government used in its own transaction from the budget allocation, that's the preparation, the execution, the reporting, everything is all encompassed in one. So the issue of always going to say, oh, we're looking for data from here, for us, at a click of a button, we can actually have an audit trail and know what is going on. But why we appreciate the guideline, no longer manual, right? The guideline of the Basic Care Provision Fund, because when we went through it, it was something actually that we really appreciated. One thing is to have a guideline, another thing is to follow it to the letter. So that's where the issue is. In the course of this discussion, I was just asking myself, is it possible for us to have, or maybe use the same system as a give mix, whereby as you're implementing, if your accountability framework is already embedded in the manual that you're actually implementing. I think that is key, because when you say you're implementing, then you now go to another place and say, okay, you're bringing another instrument to come and say, okay, standardize your process of accountability framework. It now boils down to what I was telling Dr. Gaffa yesterday. He listed the different kinds of accountability. During tea, I said, I think we need to add that of personal accountability. And he said, some people don't even have conscience again. So, so that's the story for another day anyway. But for me, we need to sit down and we brainstorm that whatever framework we're going to use for implementation, let the accountability framework be embedded in it, so that when you're doing that, as the system is flowing, you can actually be seeing the whole process as it goes. You can hold people accountable, and of course, it's transparent. Now, one key thing about transparency is this. Of course, we are apostles of the open government partnership. Let everybody see it. If people are not seeing it, then I don't understand why will you say there's any accountability? Because from the accountability, you get to transparency. And the key thing about transparency is access to whatever information to the public, whatever you're doing. So for me, my advice here is this. The first step for us is whatever framework we've laid down, whatever guideline for implementation, let's try and brainstorm
to data to be able to run such credible assessments that you do?
Thank you very much, Dr. Francis. So throughout our work on working around accountability in our organizations, we've had major key challenges, I would say. And firstly, I will mention has to do with access to information, having conversations with stakeholders. The moment the stakeholders are aware that we are here to speak to them about accountability, what they are doing, they tend to shy away from it, not understanding that we just trying to, align what, their input and their output is, what the progresses are and the challenges, and also highlighting, some of the successes, the challenges. And then another one I would also say is access to information, access to data availability with regards to interventions. It's readily available. It takes like forever to be able to extract this information. So I'll just cite example with the presentation I did yesterday. Like I did mention yesterday, that presentation was based on the data for 2020. In working to actually retrieve the data for 2021, we know that COVID came along the way and it was also a challenge, but it could have been better than the way it was. So it took quite a while for us to be able to obtain that 2021 data. As I speak to us now, we've been able to obtain that data, and we are on course to updating that scorecard. But this is something that everyone, all the stakeholders at all levels needs to understand, that we are CSOs, we are just in the space to supervise. The government is the implementers, and we should understand that as CSOs, we would only support the process. And the way of being part of that process is to actually look at what is going on, yes, make suggestions, and forward.
Yes, but let me take it from there, Memuna, and I want to put you on the spot.
Okay.
So when you say that you had challenges picking up the data and you finally did, can you tell us? So what did you do to open the tap? Okay. So what handles did you turn? So what knobs did you turn to be able to get that data that you couldn't get earlier on? This will help us because there are quite a good number of us here that have also been trying without success to do what you have been able to do. So just one or two things that you did differently to get the data out. Yes, go ahead.
Okay, so importantly to mention is that stakeholders collaboration. There's need to build relationship, not just, I'm trying to say there's need to build relationship organization level. You need to identify also stakeholders that you can work with that can help you push forward what you need in the various departments. So I would say that stakeholders collaboration is very important. Find those key persons that can actually help you drive process. Important.
Excellent.
Thank you.
Because I want to go to Jamila next. There are, as of yesterday, yes, I cannot really count the number of frameworks and mechanisms and systems that we presented. So those were the ones that we presented that are existing. And there were multiple of those systems that people are running, even in the same states, on the same basic healthcare provision fund. But again, not just the basic healthcare provision fund, this is also what we see in primary health here, this is what we see in moving forward, because I want to believe that, and this system or mechanism we put in place moving forward. How do you think we need to move forward, bringing all of those together, integrating them into just one framework that works?
Yes, thank you very much. Institutionalization of it, and also agreeing to implementation, agreeing to the custodian, and then moving forward, at what level are we going to review, and so on. I think it will go a long way if we have one accountability framework like we have in Kaduna State.
Yeah, thank you very much. Let me take it from your mouth, Jamila. You're talking about institutionalization, and you are the second person, or even the third person that has talked about this institutionalization. It started from Juliana today. So again, Sati alluded to it, and you are talking about it again. Let me get back to Dr. Kara. So we are talking about this institutionalization. So we assume that at the end of the day, we have come up with one robust accountability mechanism or accountability framework for the Basic Healthcare Provision Fund in Nigeria. So what would be your suggestion in terms of institutionalization of the way we want to administer it moving forward? Because sustainability is important. So I am here today working with WHO. I may not be here tomorrow. She is here today from Kaduna State, right? She might not be there tomorrow. So what do we do to institutionalize it so that when we are not here, others who will take over from us will also be able to continue it, and not only to continue it, but to make it better?
All right, thank you very much. Yes, issue of institutionalization is very key. So in the event that we happen to come out with a very robust accountability framework, first of all, it has to be accepted by all, in the sense that it has to be validated at the highest level, the level of Ministerial Oversight Committee, and then probably even elevate it higher. There is also need for us to, in the process of reviewing the guidelines subsequently, we should be able to inculcate such accountability framework in the next review of the Basic Healthcare Provision Fund guideline. And then there should be also capacity building. There is need to build capacity building of the implementers of the Basic Healthcare Provision Fund on issues of accountability. It is only when you are knowledgeable enough that you'll be able to actually implement the accountability framework. Again, issue of political will. There should be advocacy at the highest level, to ensure that people know that this is their entitlements and this is what they are supposed to get. And then these are the frameworks for the accountability framework. I think it will go a long way to strengthen the institution. Thank you.
Thank you very much, Dr. Okara. So, and I think he has really done a good job in terms of institutionalization. I see that Juliana wants to add to that institutionalization. Yes, because you line, then we mention. Now, I believe that there are a number of other ideas that will be coming in this direction. There will be a session later on today to be able to discuss that. But do you have more ideas about this institutionalization? But something that you need to add to it, which perhaps is my very last question, is, so two questions I'm giving you now. So first, about ideas about that institutionalization. The very last one is about the dissemination of the information that comes out of it. So our colleagues that are already working in various states and other places, even the Mamaye teams, shared ideas about this dissemination. I will need you, Sati, to also speak to this dissemination going forward. If we do all of this and it does not achieve its primary aim, which is arming and supporting and empowering the citizens to have the information and data they need to hold the custodians of these interventions accountable, then it has failed. So how do we ensure that we put it in the appropriate channels and media and forms that will be available to those citizens that we want to use this? First, talk to the institutionalization. Second, to the dissemination.
Dr. Kuije, those two questions are like 4 days workshop combined to answer them. Dr. Okara has alluded, I would say allude, because he didn't quite nail it on the head about who should. So I started talking about it, who should own it? Not own, we should all own it, but who should be responsible for tracking it, operationalizing it? Where should it sit? So I think it should sit with the MOC, Basic Healthcare Provision Fund MOC Secretariat, and they should be responsible for ensuring its institutionalization. So apart from all he said, I also started to talk about the need to make it more robust and the fact that there were some areas should be included. The demand side, for instance, is absent from it, working with community structures. So we are citizens, we are CSOs, and again, talking about holding ourselves accountable. It would be important for us as citizens and beneficiaries to also hold ourselves accountable for utilization. All of those will feed into, perhaps when we go into discussing into breakout sessions later, we will really need to deep dive to say, is this robust enough, or yes, the community structures are missing. So I'm letting you know now that I'm not prescribing, I'm just saying it would be a good idea. And then the secretariat would also need to hold routine tracking or meetings. I really don't like to use the word tracking, but say quarterly, for instance. We have to be able to get progress against the framework, and it would mean bringing on board every institution that should be represented. The media should be there particularly, and the civil society organizations, and they should go with the secretariat when they are even going on their routine M&E, and then accountability. People have said that they are the same, but I really don't agree that, I mean, they are one form of the other. right? But civil society organizations need to be part of the MOC secretariat. I don't think they're even right now members of the MOC, correct me if I'm wrong, but they should be there, and media should also be there. For the media, for the other streams or the other institutions, I also think that beyond this routine tracking with the MOC, coalition, so that's why CADMAM is here. They are established, the slums, I'm sure most of us know what the slums are. They are in most states, they are vibrant, and a lot of them are beginning, they were originally set up around maternal mortality issues, but most of them are beginning to take on basic healthcare provision fund as well, accountability, of course, linking it to maternal and child health. And I think they should also be worked with, partnered with, right, to take on, I told you I have a lot, to take on, let me finish this point, to take on this accountability issues, instead of establishing new structures. If they're already doing it, work with them. The gateways are also part of these coalitions at state level. For dissemination, let me stop there. For concerning dissemination.
Yes, just one point on dissemination, then we move to Sati. Well, we can go around in terms of that dissemination, because that's actually the last from my side.
So I think we need a dashboard. Okay. Right? Every other thing can feed into the dashboard, whatever comes from the CSOs or the media or the MOC, but we need a dashboard that will be available to everyone, to the public space, to know where they are and where results and findings will be uploaded. Thank you.
Okay, excellent. So, Sati.
Okay, thank you very much. Let me just build on what Madam has spoken. Dr. Kara, I think you have already given us the whole process we're supposed to take to achieve this accountability framework. But where I'm coming in now is the actual practicalization of the process. Thank God there's technology, and technology has made our work easy. You're investigating, or maybe you're trying to review what somebody has done, what he or she, I think I saw something on social media. They said for you to start to know how to plan your life, go to the bank, look, let them give you your account statement. Then you now know which direction your life is taking. Yes, so the same thing can apply to us. We sat down here. Now, if you're spending your money on chocolate, you know where you're heading to. If you're investing, you know where the money is going to. Now, as we're discussing, I still come back to the same point. Madam ended up by talking about the dashboard and designing using technology. Yes, we're not going to get it one day, but if we're serious about this, we're going to actually need to actually design a very good accountability framework that will take care of the budgeting aspect. Now it solves one problem. State commitment is 40%, right? 25%. Now, can you give a state money if they have not made the 25%? No. Ideally, no. But maybe there are exceptions. But then if you don't want to put exception, what it means is that you have the budget aspect, allocation aspect, and then there is this cap. Once any state uploads this 25%, it reads, then the state can assess what is supposed to come from the basic care provision fund. That is there. Who are the people that are supposed to see this? The MOC can see whatever everybody is doing. Then each state can see what they themselves are doing. Then you now know that when it comes to execution, now whatever execution you carry out, the whole process is there on the dashboard. And whatever you're doing, you spend this money on this, you've done this, the MOC can sit down at the comfort of their office, they are seeing it. You also have the M&E dashboard also, and which you can also see. Now that's where, of course, the CSO come, because they are on ground in each state, they can actually report what is going on, and of course, upload it there, and everybody sees it. So now coming back, sorting it out on a quarterly basis, then we're going to have like an arrangement, I don't want to call it a clearinghouse, where we all see and we review all this. Now it makes it easy. The information, we have people with different level of access and information they can see. So you don't need to start begging somebody to say, okay, please get us this. One good thing about this, the information will be there for eternity. Because if you keep on doing the paperwork, the person leaves, the file leaves, or the file gets burnt, it's gone. Thank you very much.
Thanks a lot. And then finally, thanks a lot, my fellow participants. You have been a very wonderful audience, and I know that there are people who are also online. For the past 20 minutes or thereabout, we have been brainstorming on this matter. So your thoughts on the dissemination?
Okay, so I know a lot has been said about dashboard. I'll just want to add that we could also explore having to develop like policies happening. And then also in addition to that, we could have something like a manual or a guide on how to use the framework so that whoever picks it up, this is a document that should be made available, to anyone who needs it. And when the person picks up the document, the person should be able to look into the results and be able to make sense out of it. So that's my contribution.
Thank you very much. I hope somebody is documenting all these very beautiful thoughts coming out of this panel discussion. Yes,
Okay.
Jamila.
Thank you very much. So yeah, I like the idea of having a dashboard, and then I'm thinking of the dissemination is not one-sided. I thought of what about the other people at the grassroots level, if you want them to really engage with such a beautiful innovation, something like this. I want to also add that we can have something like the scorecards she mentioned. Maybe we have like a multi-stakeholder dialogues. For us at Kaduna, it really worked for us where you have a multi-stakeholder engagement and sharing of these findings and whatnot from the information that you have tracking, or let me not use the tracking, using the accountability framework to tell what is exactly happening. And so you'll be able to move discussions around. That's where also the media comes in. So for instance, we are not only talking about having civil society coalitions, but we can have the journalists coalition, something like Journalists for Better Health and other stuff like that, to disseminate such information from the findings that are shared at the multi-stakeholder gatherings. That's like a step forward from engaging with the dashboard. Thank you.
All right, thanks a lot. So let me turn from the panel now to the audience. And I know there are quite a good number of questions that we didn't answer from the last session. I'm looking at, I think Ifoma, right? I'm looking at you and I'm saying this. So there are some questions you wanted to ask that you didn't have the opportunity to ask. This is the time. And I know there are others who are here. So please, IT, help me. If there are people that are online that want to just ask 1 or 2 questions, this is the time before we wrap up this session. But while the panel discussion was ongoing, so one of our very big masquerades entered the hall. And by the time she was walking in, I was like, this discussion wouldn't have had much meaning without the contribution of our own dear grandma, Auntie Lola. So she's here, and I want to hand over the microphone to her. For those of you who know her, she's a veteran. She's been in this business for before some of us were born, and she's still here giving us this support, ma. So thank you so much, ma. We very much appreciate you, and we really cannot appreciate you enough for all the support you have given to this country and all the numerous achievements we have made, giving your assistance and support. And we can't get tired. And so I want you at this point, ma, to give us your words of advice as usual before we wrap up this session. So let me give the microphone to our mommy and grandma.
Thank you very much. I'm just coming in from Lagos, and I saw the topic, accountability outcome for health, and I said, even if it's for 2 minutes to see your faces, I'll be here.
Thank you.
So, Dr. Francis, thank you always for the honor you always give me, and may God honor you more.
Amen.
Yes. I was a bit confused as usual. It's only Jamila that spoke about accountability of those people at the grassroots, because you see, I sometimes get confused. Dashboard. My people in the village do not know dashboard. So I was just saying to myself, dashboard. Who are we accountable to? It's a community. So that's why I was scratching my head that how can we give the information of the framework to those people, my sisters, my family in the community, for them to hold me and you accountable. Because if we don't give them information, they cannot hold us accountable. She spoke about scorecards. Some of them are colorblind like me. Go. So please, if we have idea on how to make sure we reach the community, I would really love that. That the community must understand their role in accountability. It's all about them. It's all not about me and dashboard. And people are tired of me and you. I went to Nema, I was asking him, how do you talk to the people on the street on research? They don't understand me. So please, I'd like us to dwell on that. Then I didn't see MPCDA. Are they here?
Yes, ma'am.
I saw him talking on the phone outside. Go.
Yes, they are here.
Which one? Which one is here? Okay.
MPCDA, right?
Huh? Yes, sir. Huh? Yes, ma'am. Which of you is there?
She's one of them.
Okay, what's your name? Sakina. You know, I agree. I love slam. I love all those ones. Anybody that knows me knows I love something in life. The World Development Committee. I really love it. That's why I'm asking for MPCDA. Slam is made by partners. All those ones are made by the WDC. It's our own, by us, for us. How do we make those WDC? Ask the councillor, the LGA chairman, not asking them the delivery of their child. How can we make them understand this and ask me and you? So that's why I look for MPCDA. You know, I'm clouded. I don't have an answer, but I just want us to. Julie, you are here. You are community like me. Those people, how do we make them understand? We are reaching that stage. I'm begging now. The time is now. The time is now. In the next 12 months, they will elect people. Sure. They are the ones to elect. Most of us will not go to the polling booths. They are the ones going to go. So let's think of a way to engage them and let them ask their councillor, ask their facility, ask their chairman. This is the accountability. This is what we are supposed to have. You're not doing it. What's next? I hope I'm not.
Thank you. So for those of us who know her, you can see that she has not disappointed us. She can always deliver at any time. Wake her up from sleep and ask her to deliver. She will deliver immediately. We are very proud of you, ma. And thanks for sparing just this time to be with us. We appreciate you. Okay, so more questions. Yes, Dr. Gafar. Well, let me give to Ifoma, and then we'll come to Dr. Gafar.
So good afternoon, everyone. I think from the last presentation by Dr. Dogara, so this question is directed to him. You mentioned, sir, that the ambulance service delivery will operate like Uber or Bolt. So I want to ask, if it's going to operate that way, are you talking about having third-party service providers on board, or is the ministry under that I'm going to take that on board? And if that is the case, then how are we going to monitor it? You know, how are we going to ensure that the vehicles are equipped with the necessary apparatus and equipment needed to ensure that victims, can get to the closest service delivery, the closest hospital or facility, without having to jeopardize whatever is left of that person's state. Then also, if there definitely has to be a criteria. Is that criteria available, and how soon can individuals or organizations have access to that criteria and guideline? And I think maybe lastly, if we are there is a remuneration process. Now we know that nobody desires to have accidents happening on the way and all of that. This is not a quick money-making venture. That we shouldn't look at it that way. What is the incentive? When I have that criteria, is there a cover if I were to be an organization or an individual who wants to come on board and offer that service as a third-party person? Is there an incentive? And why would I want to join?
Thank you. Thank you very much, Dr. Gafar. Then Dr. Henry, then my brother there, and then my brother over here, and then my brother over there, and then we will be done, at least for this phase.
How many brothers have you?
So many in the room.
So let me start by thanking the panelists for the great job done so far. I think a lot of useful insights from their contribution. So I want to contribute on a couple of areas. One is on the institutionalization of the accountability process. I think I would like to take us back to the principle that was laid out yesterday, because what we are developing here is a citizen-led accountability mechanism, which is not actually replacing other form of accountability, like what we call bureaucratic or accountability on the part of ministry, departments, and agencies. They have theirs. But what we are trying as much as possible as citizens, when I say citizen-led, does not mean only the civil society and others, other organizations as well. But this is relatively independent of the government arrangements. Because like MOC made presentation, PACD, NHIS, as government, you have limitation in terms of accountability. So a citizen-led accountability stuff cannot be domiciled within MOC. MOC have its own whatever, and we work with them to get data. There are some things as a government official that you know and you dare not report. That's the reality of life, and it's everywhere. There's something you know and you dare not report. And even when you are telling somebody, say it's off record, I'm telling you. So we have to be very, very clear about what we want to achieve at the end of the day. So I see this process domicile within a non-state actor structure. And that is why, Juliana, when the discussion first came up, the first entity you discussed with was HSRC F1, which are non-state structure. So when we are designing in terms of domicile, because I'm saying it because it's extremely important, where you domicile an arrangement determine whether it's fit for purpose or not. So that is number one. Let's think through in terms of domiciling these processes within a non-state actor structure. Number two is on the question of dissemination. So I think all of us are very right. Those that say a sort of technology-driven dissemination approach, website, dashboard, and other things, I think we are right. And our mommy, Dr. Mabo Guje, that look at it from the perspective of citizen, we are right as well. I think what is important is for us to do what I call audience segmentation. So in terms of our audience, of course, we have the political audience, we have the policy audience, we have the citizen, we have the ministry, department, and agency. And for us to look at who needs to know what and who needs to do what. The information needed by the people in my village is different from information needed by the people in the ministry, department, and agency. So when we do our audience segmentation, we look at and the basic information needed by the citizen and what is the most important approach of passing the information across to them. And don't let us forget that there are a lot of existing structure that we are not taking advantage of. Take, for instance, in Kano, that's what they call Emirate Council on Health. Very, very powerful structure. And is headed by a very old person, but very sound. You know, very, very sound. You understand issues and everything. I've forgotten what the name is. You understand? So let's map those structures and see what type of information should we give to them to do what, so that at the end of the day, we'll be able to get the great result. And as part of dissemination as well, don't let us forget knowledge management. Everything is not only about the data. We should try as much as possible to look at the facts behind the figures and what is actually changing over time. See, this accountability arrangement we are developing, there will be more questions than answers. There are a lot of things we don't know yet. It is when we start implementing it, a lot of things will now surface. We need to have an arrangement in place where we continue to look at what have we learned, disseminate it, and we will try as much as possible to see what we can do differently. Thank you very much.
Brother Dogara. Okay, he stepped out.
Go ahead.
Yes, I would have loved him to, from his last presentation, I think it was him. And okay, but again, the other presentation from NHIS, the gentleman, it's like, he's not here again. Okay, this data management at the PHC, he was referring to a situation where there is delay in uploading data so that it will be available maybe up to the MOC. I'm asking whether we can sample at random 10 PHCs and see their capacities and competencies there. That is, I wanted to support this real-time online type of accountability framework, tracking of resources, very beautiful. That's where the world is going. But again, when we look at what is available at our various PHCs as we stand today, even at the one President Buhari, where he flagged off the BHCPF at, where is that place? Kuchingoro. I don't know whether those capacities and competencies are there. But are we going to wait for all these things to be there before we start? I think we need this real-time online monitoring. Track it. Sati, from the time you release this money. But again, you drew us back that it starts with appropriation. But from the time Federal Minister of Finance releases this money, let us start seeing where it goes. It is possible. Somebody sent me a way bill the other day. However, the truck got spoiled on the way. When I went to the office, I bet I could have used the number there to track. And I did it and it worked. The truck got stuck somewhere because it broke down. Many the pipeline of development have been serially and subsequently vandalized in our country. In my former state, where me and Francis come from, it's now my former state. I'm borrowing Anambra. Anambra is my new state. Yes. A man came in and word of the mouth, he stopped basic healthcare provision fund operations in Imo State at present. He doesn't understand it. He has seen big money. They told him the money is big. He thinks is the commissioner and other people that is put word of the mouth, stop. And it has stopped. This is where we are. But The WDCs are excellent. In my community where I'm from, I chair the WDC, but just in words. Why can't it operate? The governor has his own, what he calls a community union development associations. He appointed the president and ESCO from Owerri, the capital. Those people will be leading in the communities all over the place. So our people say, look, we don't know these people we have sent to come and govern us. There are several issues. That's why I think, again, a mention was made about journalists carrying people. There is this, I expected Aminu will bring them here, a session of Nigerian health journalists or so, unhedged, they exist. Let us bring activists on board. This boardroom type of thing, Selense, as will not work again. You were not here yesterday. I made a reference to 100 million form, like this one. Yes, they have bought it all over, 20-something billion generated. But 300 and something million can't release it. So that they will stop using this thread, using tying hair. You know, when you people were tying hair before, there's this thread they use. That's what I saw in my hometown health center. They are using to repair women's episiotomies after delivery. I saw it. That's what I saw. And this money is being tracked somewhere because they have not done the silence of putting computer, putting this and so on. And the people that head these states are called their excellencies. 2014 December, the son appointed governor, now Governor Tambuwa, the son man of the year. That year, in Sokoto State, was the least immunization coverage. This year again, the Sun newspaper has made a son man of the year, a man who stopped basic healthcare provision fund operations. Where are we going to?
Wow. Thank you very much. So I still have my two brothers, one here. Oh, there are actually three of them. One there, one here, and one here. And then we can begin to wrap up. Yes, him. Then you, and then my brother here, so that we can begin to wrap up. So please make it short.
Thank you so much
yes,
for the panel discussion. It was a good one. I'm Comrade Nelson Nananwafo. I work for FINRAD. I'm a member of hedge from Abia State. Actually, I am so much concerned about when they talked about accountability framework. And our MAME that just came in talked about getting the community people involved. And when you say you want to monitor through online, when you don't have a structured community monitors, people that are on ground, like my Oga just rightly said, when you went to some PA centers in the states, in the communities, it's a very horrible situation. Even the personnel there are not even trained to know what they're supposed to do. So it is a very much important that we need to move much more further from this online tracking to get community monitors, people that are on ground, civil society members, community CBOs, people in the community that we train them capacity. They know what they're going to monitor, what they're going to look out for, what they're going to report, especially when that fund is being made available to the state. There are some states that when the basic health provision fund came, the fund moved into a private purse, and the government decided on how to spend the money because there is no coordinated civil society strength or network that monitor this fund. These funds were used into private use and the purposes. And if you go to some primary healthcare centers, you keep on wondering funds that have been released for the basic health provision fund, where that fund has been spent. So I'm of the view that it's important for us to strengthen our accountability mechanism. We should get people on ground. We should train community monitors. We should get people in the community to be aware of what is happening. They visit their the public care centers, give us result of actually what happened, how much was released, how much was spent, what are in these various healthcare centers is actually very important. And then also, you said you have been doing some accountability mechanisms. I want to find out what are the indicators. What did you use to measure progress of the accountability framework that you've have? Okay, from the ones that you have had before and you've been able to test run it, what are the lapses? What lapse do you find out in the implementation? Well, is it excellent? Did you meet the actually desired result of getting that particular result to ensure that there is accountability in the management of the fund? And then lastly, civil society has to be involved. We have to strengthen civil society coordinated network. And just because know what is happening in the states, what's happening in my state, in Abia, what's happening in the Southeast zone, what is happening across the federation. So that we can have a network of civil societies working in all these tools, giving some of the reports. And in more cases, we can begin to see how we can replicate the strategy one state or one zone is actually using to get the results. Thank you.
Thank you very much. Thank you very much. This is very, very useful. And indeed, I see a lot of these things. Okay, my friend here. I see a lot of these things that we are bringing up right now coming together. That will be the very next session. So
Okay.
Yes, ma'am.
Ambulance.
The model.
Yes,
I'm very confused about it. And then it will educate me who would use it. Who would use it?
That's very good. Dr. Okara will speak to it before he leaves the podium. Now, so yeah, yes, ma'am. So please, so these things we need to put together, and I crave to join us during the next session, where we're going to be these things and putting them together in just one document that will help us to move forward. Yes, my brother.
All right.
So if you can take 2 minutes, I would like it.
It's fine. Fine. Thank you very much. I'm Olimpo Sadebanjo, Vaccine Network for Disease Control. And I just want to share a bit of learnings from what we learned in FCT here. Mrs. Chikaofo managed an advocacy project for primary care revitalization, an IHP project in FCT between last year and this year. And there were some things that were very strange when we were doing that particular advocacy. And one of them was how we found that actually for 2021, there was an appropriation of like 750 million naira to basic care provision fund counterpart funding from FCT, although it was captured under miscellaneous. And that was the first thing. But then they explained it away, like before they were able to know, because there was a new sort of administration or so, and it was very late. They just had to add it somewhere, and that is why it was a miscellaneous. And that's number one. Number two was how we realized that they were, now when we engaged the legislators on it, the FCT committee, they were like, they have applied for different environment, that is transfer of those funds to other stuff, other government projects in FCT. And that was the second level, because I thought that this was supposed to be a statutory funding that should only be allocated for BHCPF alone. But at that point, they had already, I think they are towards where have they already, and they're already taking about 250 million, and there are still other applications to environment that money away from that particular purse.
Okay, so, so summarize.
So in summary, so I was like, and when I look at the effort of the civil society and the secretariat and the MOC, I think that we should actually adopt the hybrid system for this accountability, where we are using technology and then foot people like the communities. But it's very important for us to use hybrid system this time around, technology very importantly. And secondly, I think that this is time for us to actually bring in some legal aid into the accountability system. That is, maybe there's a time that it's a time where we have to bring in, say, EFCC to some of our engagement, because really the health system needs some cleansing. Really, there is a lot of, I think we like to do as though the civil society and government are like the same, but sometimes there are some corruptions, nuances to this particular issue. And I think that certain government agencies, and lastly, I want to suggest that there should be a particular body, almost a government body, that should be that will be statutorily given the responsibility of collecting all BHCPF related data, such that it should not be civil society moving around different government offices. Instead, we can have a one-stop shop for BHCPF related data that can be available for everybody. So I think that there is need for that institutional responsibility for one body of the government. Thank you.
All right, thank you very much. So we take the last intervention from here. I'm sorry, there are a number of our colleagues that are raising their hands. I think we would not take everyone at this point. Again, we'll move some of you to the next session when we are going to be doing that group work and a number of other things. So you can make those suggestions and bring up those interventions at that point. 1 minute, my brother.
Thank
Go
you.
ahead. Yes.
My name is Henry from HIV/AIDS Committee, National Assembly. Essentially, the reason we are gathered here concerning the accountability framework is for us to do the right thing. And when people do the wrong thing, we have problem. I heard that Dr. Gafar talked about consequences in his presentation. And I'm drawing this analogy from what the last speaker said. We need to talk about consequences in institutionalizing this accountability framework. When people do the wrong thing, the presentation earlier, one doctor said, when you don't do it, you will not, your funds will not be released to you subsequently. We need to go beyond this. If someone misappropriate or do not do the right thing, let there be legal consequences, then we will sit up. Then secondly, I want to ask, what support CSOs are given to NACA? Is NACA not also covered by this basic health fund, provision fund? And I also want to alert us. The president has inaugurated, launched HIV Trust Fund of Nigeria. What are the SOS doing concerning this, even though modalities concerning the fund management has not been released, and especially the Ministry of Health? What are we doing concerning this and CSOs? Thank you.
Okay, thank you very much. Thank you very much. That's very, very useful. We will be speaking to, well, the panelists will speak to those issues very quickly before they leave. But I have a few comments here that I need to also bring to your attention, thanks to colleagues online. This is from Charles and Aniweze. Government structure within the basic healthcare provision fund system cannot firmly scrutinize itself. The accountability framework for the BHCPF will be stronger if independent bodies monitor the implementation, ask relevant questions, and report their findings. This independent body can be created and must not be CSOs that need to be trained. It could be made up of both the public, the private sector, the CSOs, media, etc. We may not need much money to make it functional. The efficiency gain alone from a strong accountability mechanism can build up to finance their monitoring activities. From Tajuddin Ibrahim, in addition to the above, I would like to suggest a mechanism to coordinate implementing partners and CSOs supporting grants implementation in Nigeria, and let them have directory of all facilities implementing BHCPF for ease of referral and leveraging, and it will support accountability through a robust feedback. From the Global Fund, we have some CSOs that are currently implementing community-led monitoring component of the CSS interventions. They are positioned to help the implementation of the accountability framework. And again, from Tajuddin, institutionalization, accountability as part of our daily life is what matters. We can complete with reporting mechanism and follow-up action to prevent identification without remedial action. So very quickly, we need to just wrap up this session in the next 5 minutes. So we start with Dr. Kara. What is this Uber about? Okay, so what is this Uber ambulance? So that is you. And then, of course, I'll give 1 minute each to my panelists to speak to any of the issues that colleagues have raised. A lot of them were comments. So, and then you will use that opportunity to give us your very final words on this panel. Yes, Dr. Okara.
Yes, thank you very much, Dr. Francis. I think the word Uber and Bolt was just used as an example to demonstrate how vehicles just are being called when they're needed, and then they carry out services. But for the emergency ambulance services, it is expected that every state, the EMT gateway is not managed at the level of the federal. No, it is at the level of the states. Each state is supposed to have its own state emergency management ambulance services. And they are supposed to have a call center. Now, but before then, a criteria has been met. They have there's a guideline. They've actually developed their guideline. And in the guideline, there is a criteria specifically for ambulances to be used and the equipment that are supposed to be inside the ambulance. The size of the ambulance, the make, and specifications have actually been identified. So they will assemble these ambulances. Take, for instance, FCT. They will assemble these ambulances. There is a call center. So in the event that there is an emergency, you will call that number, and the ambulance is supposed to arrive within . That will start emergency management of that patient until the patient is taken to the nearest hospital where services will be rendered. It is expected that within the first 24 to 48 hours, monies will not be paid. Services will be rendered. After 48 hours, then issues of payment will come. The patient will be looked onto. Is the patient covered by any form of insurances, whether formal sector, informal sector, basic healthcare provision fund, community health insurance, and what have you? Does the patient also have the capacity to pay? Is he financially buoyant? In the absence of that, then the basic healthcare provision fund will pay for that services. So they will send the claims to the the secretariat now, just the way the NHIS is being done and the state health insurance being done, where they reimburse the claims of services that is being rendered, is going to be paid accordingly. Well, you pardon me, I am not part of the EMT gateway. I am part of the Ministerial Oversight Committee. So the technical detail of what I just explained now should actually be explained by Dr. Ahmed Seidu, who is the head of the EMT gateway. Right. Thank you.
Thanks a lot. So, yes, ma'am. So I think the idea of the EMT is to have a system that is one governed by government, funding provided by government, but services provided by the private sector. The design was to mimic the kind of ambulance services we have in the UK, which also does the same thing. They are still at the very, very early stages of implementation with some MOUs and pilot to start in FCT. Hopefully, by the time they begin, just like we are here discussing again the accountability framework, and indeed, this accountability framework will also cut across the implementation of the EMT gateway. So thank you very much, Dr. Kara. Okay. No, I don't think we will need that at the moment. We need to close this session. So let's go, starting from Sati what are your final parting words to our very beautiful audience? And are there some things, kind of some messages coming from you as an insider from the Federal Ministry of Finance to us while we work on this moving forward? You need to give us expo.
Thank you very much. If we give expo, which means that we are going away, departing from accountability. So there will be no expo on that.
Oh my goodness.
This has actually been a wonderful section because it's give and take, and I've learned a lot of things. In the course of all the reactions from the discussion of the panelists, I just did one single thing. I drew a triangle that the success of this whole accountability framework has to take to the line of triangulation. But then my brother over there brought a wonderful word that I also want to buy, that is hybrid system. The truth about it is we cannot just use one fit all system. We have to look. Mommy brought the idea that, oh, the grandmother in the village doesn't understand this system. We have to incorporate it because she doesn't understand anything about the internet.
I still think, and that's why we're here, that we need one accountability framework for basic healthcare provision fund, where every sector draws from. It doesn't preclude civil society or health sector reform coalition from developing like a roadmap to track. But when we now compare results, we are comparing across the same indicators, like what we have in the Basic Healthcare Provision Fund guideline now. So I think the confusion may be saying, let's have a roadmap for HSRC or any other coalition to track that one accountability framework. And when you're reporting results, it's important to report against or against the same indicators. That's one. Then two, the dashboard we are referring to, right? You know, Dr. Francis said just one. Everything that everyone has suggested will feed into it. Don't forget that it's a dashboard, and I said it will be available to the public. In Gombe State, they recently went from Emirate Council to Emirate Council, having town hall meetings on basic healthcare provision fund. We have the legislators doing town hall meetings, constituency meetings, all of this, the work of the WDCs, reports coming out. We need somewhere to put them for everybody to see. So it doesn't also preclude all of these other processes. It just would help to have somewhere a database, where a repository, where you can one click, open up, and you see what is happening across the country. Thank you.
Thanks a lot, Dr. Okara. Oh, he has talked. No, his final words.
Okay, thank you very much, Dr. Francis. Accountability is key.
Yeah.
People must be responsible to their actions and inactions, and you should also be held liable for any consequences. And what you are doing, it has to be open. I therefore encourage all of us that we are here to ensure that we are part of this epoch-making event to have an accountability framework specifically for basic healthcare provision fund. Thank you.
Thanks a lot. Yes, Memuna.
Okay, so my words will be that the accountability framework, of course, having a unified accountability framework cannot be overemphasized, as already mentioned by everybody. And something that is very key and important to ensure its successful implementation is the roles that every stakeholders have to play at their level. We all need to be accountable, responsive to ensure that this accountability framework is well implemented, is successful. And then lastly, I would like to emphasize that the role of the civil society organizations in driving this forward cannot, be underscored. So we need to ensure that the civil society organizations are, are on board across all the process throughout the journey. Thank you.
Thank you very much. Finally, Jamila.
Thank you very much. So I would like to say that this accountability framework is for all of us. And so we should be committed to ensuring that what we put forward, we also hold ourselves accountable. It should be transparent as possible. I also want to talk about some of these indicators that one of our colleagues here asked about. So yes, the indicators are derived from the Basic Healthcare Provision Fund guidelines, and then some of the implementation guidelines from the state at the state level. And so, yeah, they were actually shared yesterday, and the success stories were shared. Some of the lapses were also shared. One of it was the fact that we are unable to, so I want to share success on the implementation of the implementation plan, yes, quickly.
No, we don't have time for that.
Okay.
Just wrap up.
Okay, so I just want to say that co-creation is important when we want to really put forward this accountability framework and see success. See that we achieve success in the implementation. Thank you.
Yeah, thank you very, very, very much. Please, a round of applause for the panelists. And another round of applause for yourselves. So it's completely an hour. No, come and take a group photo. Come and take a group photo. An hour, 15 minutes. An hour, 15 minutes of very useful discussions. And hopefully, what has come out from here will support us in developing the action plans that we want to develop, come forward, in the next, on this platform. In the next session, which Juliana is going to moderate. So thank you very much. So is that going to be before lunch or after lunch?
We already have the one in the basic health provision guideline. So what we want them to do, we'll give them empty templates on the laptop. This is very important because we are the crux of these 2 days, and if we miss it now, then so what we think will work is this. But please let's know what you feel the way we should go. We already have the guide. Already have a framework in the guideline which Dr. Okara presented and which is being flagged. They are across 3 elements. We have governance, we have funding, and we have program management. We are suggesting that we look through what is already there. They have told us to feel free and generate additional elements and indicators that may be missing. For instance, NHIS, when they presented, they had under health services, they had service utilization. That's not part of the guideline. And I talked about the need to include demand side indicators. So we are suggesting we split into 6 groups. Each of the group will be on 1 element. So we'll have 2 groups of the same element. We have 2 groups of funding, 2 groups of governance, and 2 groups on program management. We will need someone with a laptop to help rapporteur in each of the groups. The template is going to be given to each group as an e-copy, and then this one from the guideline has already been printed. Damilola, please, let's distribute what we have. So I think we agreed we'll have 2 per table, and then we just feed into the template what we feel. Elements that are not there. For instance, should we say service delivery should be the 4th element? Should we say community structures, right, for demand, right? So let's have elements and then suggested indicators underneath it. I know that this is just a first of a series of meetings I'm anticipating we will need to have to generate this one framework and the approaches we are going to adopt to operationalizing. And then for Health Sector Reform Coalition to also develop a plan for tracking as the primary CSO at the federal level in the health sector. Suggestions, please. Do we have suggestions to this or additions or recommendations? Or are we, all those who agree, say I, A. Do we agree? Say A or I. No, that's not, it hasn't formed a quorum. Okay, so a show of hands, do we agree with this suggestion? Are we hungry? I know we are not. So we'll just do an hour of this, and then I think we can, we should be done, Max. All right, so I think we've agreed. I think we need to either merge 1, 2, 3, 4, 5, 6. Okay, so maybe we don't move. Yes, so maybe we take tables and then any other person, participant not on that table will join whichever table they want. So this is table 1. This is table 1. This is governance. This is table 2. This is funding. This is table 3, and this is program management. Table 4, governance. Table 5, funding. Table 6, program management. No, I think this is more robust because I'm going to have others. This is larger. I'm going to have others join you. So please, let's move. Maybe we need to even bring the 2 tables together. So please, you can just move to others that are not, that are sitting around tables that are not designated. Please join designated tables, please. So group 1, governance. Group 2, funding. Group 3, program management. Group, Group, no, we don't have a 4. What group is it? Okay. No, we don't have group 4. Okay, 4, 5, 6 is the same thing anyway. So group 4, Group 5, Group 1 governance, Group 5 funding, and then program management. Okay, so let's Damilola, let's move templates into laptops, and then please distribute the printed documents. We start now. We should be done in 30 minutes, I think, or an hour max. By 2:45 minutes, I think. By 3:15, we should be wrapping up. Stable is still free. Governance. Who wants to? Please, let's move. Take up our various, decide where you want to be and quickly join. Thank you. Governance, program management, funding. This is empty. Which? Big people, big masquerades, but he's there. I think he can help. Members of the Secretariat, I think this is a group work that's important for you as well. So maybe 1 or 2 people should stay back with the equipment while the others join. Huh? Virtual participants, so as we did yesterday, please also send us suggestions of elements that you think should be added and indicators that you think would make it more comprehensive. Thank you. We have 2 groups of people. We have governance, we have funding, we have program management. So it's just to join one of them. Governance. There's governance, there's funding, and then there's program management. This is governance as well. I think you should be here, ma'am. Dr. Dafai is funding, and they are relatively young here. They will benefit from your experience. Funding. This is governance. This is program management. Okay. The plenary, okay. Thank you so. Thank you so much for your contributions and taking time out to put this together and generating a consolidated accountability framework for the Basic Healthcare Provision Fund led by Nigerians. Thank you very much. A round of applause for everyone. Let's take our seats. The next session will be plenary, facilitated by Dr. Gafar.
I just so that we can see. Hello. Hello. I'm very sure we are getting there. And I promise you in the next 10-15 minutes we'll be done. So one house, please. So let's go to the last section quickly. You recall yesterday when we started, we all agree on the objectives in terms of what we should accomplish at the end of the workshop. So in order to hold ourselves accountable, hello, one house, please. One house, one house. This is a very, very important section, please. Of course, all the other sections are important. So please, I would like to crave your indulgence. Please give me your attention. I need your attention in the next 10 minutes, please, so that we'll run up quickly and we are done with this two-day workshop. So like I said yesterday when we started, so one of the objectives of the workshop is to chart a course of action for effective implementation of a Basic Care Provision Fund accountability framework. So a consolidated accountability framework led by the citizen. Sorry, are we ready for this section? If we are not ready, I can give you 1 more hour to complete what you are doing, then we'll come back. We are very flexible. So, you know, let me share this story. Now, when we were in medical school, during the final exam, please listen now. During the final exam, so the external examiner asked a question and the student was not able to answer. And the question was that, why come you don't know this? And the student said, sorry, I didn't have much time to prepare. And the external said, aha, let me give you 1 more year. So that you come back, by then you'll be better prepared. It's okay. And the student repeated the class. It could be that mean. So basically, we'll be looking at what are the key next steps of ours, so that this will not just be another talk show where we talk, and nothing happens. So we want to do things differently. Somebody says to turn things around, we have to do different things and do things differently. So we want to do things differently, to agree on an action plan, which will again form the basis for holding ourselves accountable. So based on the conversation since yesterday, we've listened to a lot of presentation, a lot of conversation, and we've been able to synthesize key themes from what we have discussed, what we need to do. So the single most important thing we are going to do is to first of all look at some themes that emerged and agree that probably it captures the areas of interventions we want or not. If there are other things we should put there, we agree. Sorry, so we have our intervention area, task, resources needed, responsible, and timeline. But of course, I would not go into the details of populating everything there. So what is very important? And if we're in agreement, let's show. One, we thought one important area of our next steps is for us to integrate all existing accountability framework. Don't forget that one, the Basic Healthcare Provision Fund in its guideline has some accountability elements. A number of partners and CSOs, they have implemented other accountability arrangements which they've presented. So what we are trying to do is that, number one, how do we integrate so that we have a consolidated citizen-led accountability framework for Basic Healthcare Provision Fund? Are we in agreement or not? Okay, it's only Mama that is talking. Are we in agreement or not? Okay, again, from the conversation so far, it shows that there are a lot of people, there are a lot of structures, there are a lot of organizations that we need to bring together to leverage their resources to be able to achieve this accountability aim. The other time, Dr. Ogwe was talking about around 6,000 facilities participating in all the local governments. So if we are able to map some of the structures that are operating in many places, I think it's to our advantage. Tajuddin Ibrahim of Global Fund mentioned one structure that Global Fund is using. We have what we call chiefs, we have traditional rulers, we have many other structures. So we want to do the mapping of stakeholders so that we engage them with this, because this is not only Abuja level accountability framework, it will get to the grassroots. Are we in agreement or not? Yes, ma'am. Yes. Okay. Okay. So we'll do the mapping of mappings, right? Okay, it's part of it. Absolutely, absolutely. So I think we'll put that in the footnote so that instead of all those mapping that have been done, we'll put them together. Absolutely. So put the comments there so that exactly. Thank you very much. So another area we are looking at is that when we consolidate everything, we need to disseminate. We need to say, okay, the product of this work, what every other person is doing and everything, looking at the most relevant indicators to track and everything, we need to disseminate. Are we in agreement? Hello? It's like the sugar level is too low. Should we replenish and come back? Okay, thank you very much. At least you have a loud voice. Yeah, so again, capacity building is very important. Starting from our common understanding of what is accountability, how do we do it, what are the processes involved, and when you bring these stakeholders that we identify together, we need to strengthen their capacity on that. Are we in agreement in terms of capacity building? Of course, the details of capacity building at national level, state level, what form will it take and everything will be under the specific task. But we have to agree on that major area. Are we in agreement? Absolutely. So capacity building for the organization that we must have mapped. So that's what we are referring to. Okay, we're in agreement on that. Again, coordination is very, very important. We want to do the mapping of a wide area of stakeholders. So how do we strengthen the coordination and the institutional capacity to do that? Again, in terms of what that means, we spelled that out specifically in terms of what we mean by institutional capacity, who is going to be the institutional home, what institutional capacity is needed to do that. Are we in agreement? It's not good for sugar level to be low. Are we in agreement? Okay. Again, part of what emerged from panel discussion and other conversations is that this shouldn't be a one-off discussion. We need to meet from time to time, and not only at Abuja level, at the subnational level as well, maybe on quarterly basis, when this accountability framework is populated to stimulate conversation on issues identified and what we need to do differently. So we think having sort of a quarterly engagement is very, very important. Are we in agreement or not? Why are we agreeing on anything? On everything? And there should be some disagreements. Okay, if I want to disagree, yes.
I was just wondering, when we bring together all the accountability frameworks, everybody has been working on, and bring together the whole mapping, are we not supposed to sort of validate the consolidated framework before we disseminate? Yes.
Okay, that's fine. That's fine. Good disagreement. Are we in agreement with that? Yes. That we need sort of a validation, not just hello.
She's valid. She's valid.
Valid, right?
Yeah, valid.
So probably before the dissemination, we should put something like validation as well. Great. Again, in terms of dissemination, in terms of how people will see what we are doing, we need a platform, we need tools that is going to be appropriate for different segments of the audience. For the rural people, for the village people that are using the facility that they don't have access to internet, not to talk of a website or a dashboard or something. Even illiterate, yeah. And for those that are able to access, so like having a sort of a dissemination platform, whether appropriate one now, whether it's going to be technology driven for those people that are able to, on the favorable side of the digital device, because there are different types of people. There are those on favorable sides and unfavorable sides of digital device, digital divide. So then in terms of knowledge management, we need from time to time, after developing, finalizing it, populating it, disseminating it, implementing it, we need to reflect from time to time in terms of what is working, what is not working, what lessons have we learned. So we thought in knowledge management is another area. If you see very well, this is an intervention area, not specific task. I think what we are going to do is to, if we're in agreement with this area, we are now going to look at what are those specific tasks, what resources do we need. So in addition to all these areas, are there other important areas that are not yet captured in terms of important next steps from this workshop? Okay, Chief. Okay, can somebody expand?
I just want to talk about the learning agenda is there. Is the sharing part.
Okay.
You know, okay. Learning from each other and all of that.
Yeah. What is the question?
No, the knowledge management.
Yes.
I didn't see the learning agenda. So
okay, so the learning agenda is there. And basically what we mean by learning agenda is that what do we want to know? The known unknowns. What do we know that we don't know? So that during the process of implementation, we'll try to know what we don't know. But we have to know what we don't know from the beginning, that we are not sure of what works or what doesn't. So that's why we are going to have a learning agenda. And I don't know whether there is provision for learning agenda already in the basic care provision fund guidelines, so that we are not, there's none. Okay, so we'll do that. So any other area that is very important going forward that we are yet to capture in terms of broad areas now? None? Okay. So So we have to agree now because this is democracy. We have to agree. Do we use some few minutes to identify key tasks needed or resources needed to do some of these areas? I'm mindful of time. Let's use democratic means. Should we agree on some specific, like for example, when we say we are going to integrate existing stuff, there's some specific tasks there. Like for example, somebody has to look at all the framework presented or presenters in CS today, look at what we just did today, try as much as possible to harmonize and so there are some specific tasks. Or we should leave that to the secretariat to do. Secretariat. Okay.
I wouldn't know if that should appear here too.
That's a minute stuff. That one will be taking care of that. We want to integrate the existing framework. It will now incorporate the elements that you just discussed now. So that's an element under accountability framework. So what's our agreement? Do we ask the secretariat to populate some of these aspects? Okay, so Okwemi, Mama is asking, what are the secretariat? Okay, exactly. Yes. Now, right? Ma, from experience, what is not done before we leave this place? But yeah, blood sugar is actually very, very low. I think probably what we can do, I think the most important thing is that we have agreed on the intervention areas. Most important area. I think the secretariat and some of us can work together to identify key tasks, resources needed, timeline for it and everything. But I want to find out for the last time, do we have any other important thing that we should do to actualize our objective that is not yet captured in terms of a major area? Okay. Yes, ma'am. Okay, so you can have volunteers, right? Okay. So I think Mama is making very important point. We can even work virtually. You know, technology has made things and agree maybe Friday morning or something, like just more than 30 minutes or something. So Mama is leading the way. That's demonstration of leadership. I don't only clap now, she has challenged us. Who else? Who else want to join the group so that by Friday morning we just work virtually to populate this? Who else? Okay, please mention your name and secretary is your name.
Okay, Olympus Adebanjo.
Okay. So Olympus Adebanjo will join us. Who else? Of course, Okwe is there automatically. Okay. Memunat will join. Maybe just one more or two more so that we are done. From HSCL, there are a lot of people from HSCL there. Just two of you. Ifoma.
Save the children.
Ifoma there. And save the children. I think that's fine. Then somebody must come from list there. Who? Okay, what's your name? Elizabeth Adiyemo. Please, okay, let me take all their email addresses. Okay, Dr. Abdul, that's fine. I think so. Let's try to meet Friday morning. Something we'll communicate via email. Yes, ma'am. No problem. You're welcome. We'll be highly privileged to have you. Okay. So I think we've done a great job. So on this note, can we appreciate ourselves for that great job, please? Can I see the agenda? Okay. So Juliana, you are
you know, should I just, Dr. Celeste will have. So before I hand over to, hello, before I hand over to, is Dr. Celeste here to, okay. Before I hand over to Dr. Celeste, let me use this opportunity once more on behalf of our partners supporting this process to congratulate us for this first step. I think it's a beginning of process, and I'm so excited with the quality of conversation and suggestion. And even among our online participants, honestly, since yesterday, we've received very, very valuable contributions from them. So let's try as much as possible to sustain this. Again, the Secretariat will work on the report of this so that it is circulated for our reference. So we are going to work by Friday to finalize this action plan. Then we are going to disseminate, and please, let's try as much as possible to hold ourselves accountable for the implementation. Because in Nigeria, our shelves are full with documents that are not implemented. And so let's try as much as possible to do things differently. On this note, I would like to hand over to Dr. Celeste to wrap up and finalize this stuff. Thank you.
Thank you, Dr. Jafar. You've done a wonderful job. There's no doubt about that. As part of the wrap up, I wish to thank all the participants who participated in this at this workshop, which has been a huge success in bringing together all the stakeholders to discuss a roadmap on how to enhance accountability in the management of public funds spent in the health sector. The discussion has been very engaging, interactive, and productive. As a wrap-up, I wish to summarize the resolutions taken at this forum. These resolutions will be carefully reviewed, and the action points, which was discussed by Dr. Alawode, will be tracked and followed up. I will say that this forum will not be a talk shop, but rather be the first step in a series of processes that will lead to the development of a framework that will enhance accountability outcomes for healthcare financing and BHCPF in Nigeria. The resolutions are very similar to the action points. The first is that the Health Financing Accountability Forum has appraised existing health financing landscape in Nigeria and noted that there is suboptimal funding for health and inefficiencies in the health sector. We have therefore resolved that there is need to improve efficiency in the utilization of public funds spent in the health sector through the development and operationalization of an accountability framework. This forum underscores the centrality of raising the accountability bar to reposition the Nigerian health financing landscape. There is need for collective leadership, where all stakeholders will come together in a collaborative relationship to ensure that the objectives of the Basic Healthcare Provision Fund are actualized.
So it's a good action to work on funding.
The forum knows the current efforts geared towards raising accountability bar for BHCF.
And these are just what we added.
We know that these stakeholders are different stakeholders are developing different accountability frameworks. We have therefore resolved that it is important to harmonize or integrate, or rather consolidate the existing accountability frameworks into one framework that can work for all of us. HSRC and HEFON, with the support of partners, will facilitate the development of such a citizens-led framework from the proceedings of this forum. Such a framework needs to involve all the stakeholders and will be validated at the highest level. There is need to conduct the mapping of all the stakeholders at all levels and build their capacity and accountability framework implementation, as no one can monitor what he does not know. This forum will continue to work with partners to build accountability, to build capacity of the stakeholders. The HSRC and HEFON will also work with stakeholders to strengthen the coordination mechanism and build institutional capacity for accountability framework deployment. The forum will work with other stakeholders to develop a technology-enabled visualization system, a dashboard that can be hosted on a website so that all Nigerians can have access to BHCPF data, online real-time, that can be used for effective decision-making. The forum will also develop effective knowledge management system, including learning agenda, success stories, and policy briefs, which should be wisely disseminated among stakeholders. The HSRC and HEFON will continue to work with all relevant stakeholders to build all the gains of the forum to raise the accountability bar to achieve more money for health and more health for money. Finally, just a personal experience, which I want to share. Several years ago, I went for a job interview. Then I was briefly in Liberia, and I think the organization I wanted to work for, they asked, they had accountability issues. And then when I was during the interview, when they were asking me some questions, I said yes, that I'm a man of integrity. One of the interviewers asked me to define the word integrity. Honestly, I don't think I did a very good justice to that definition. But I think from this workshop, my personal take home is that the word integrity is that we should hold ourselves accountable in all we do. On that note, I wish to thank all of you for being here for this workshop. And God bless all of you as you go home. Thank you very much. Okay. I think we have to go for lunch, please. Yes, I don't know who I will give this. Okay.